Good morning, and welcome to the Assembly Committee on Ways and Means and Senate Committee on Finance Joint Subcommittee on Human Services. Will the committee secretary please call the roll?
Senator Cannizzaro. Senator Dondero Loop. Senator Hammond. Senator Kiekefer. Senator Ratty. Assemblywoman Benitez Thompson. Assemblywoman Carlton. Assemblyman Frierson.
Here.
Assemblyman Roberts.
Here.
Assemblywoman Titus.
Here.
Assemblywoman Tolles.
Here.
Assemblyman Watts.
Here.
Chair Monroe Moreno.
And I am here. Will you please mark Assemblywoman Benitez Thompson present as soon as she arrives? And again, good morning, everyone, and welcome to our committee meeting. We will be hearing six budget closings from the Department of Health and Human Services Division of Healthcare Finance and 2 from the Director's Office. And without further ado, we will get started with the first one on our agenda. Actually, we're going to let the documents get handed out. Okay, it appears that everyone has received their documents. Can you all hear me better now? Yes? Okay. We have had a hearing and a work session on these budgets, so this should be like a refresher for these budget closings. And with that, we will go to staff for account 3158. Good morning.
Thank you, Madam Chair. Kathy Crockett, Fiscal Analysis Division for the record. The first budget is the administration budget. It begins on page 3 of your packet. This budget provides administrative staff and support for services for the Division of Healthcare Financing and Policy, which includes administration, accounting, budgeting, personnel rates, compliance, utilization, review, privacy, recipient rights, provider enrollment, and information technology. There are 3 major closing issues in this budget. The first issue relates to position changes. The governor recommends additional funding of $1.1 million, of which $479,301 is general fund for notable position changes in this budget. The first position change relates to the state dental health officer contract position. As part of a new funding mix and structure for the oral health program established pursuant to NRS 4392791. The governor recommends funds totaling $489,404, of which 50% is general fund and 50% is federal fund to fund a contracted state dental health officer position as discussed at the budget hearing. On March 23rd, 2021, the Governor's Finance Office submitted Budget Amendment A 2150-83158, eliminating the original E400 decision unit to add the contract position and adding a new E125 decision unit. And rather than adding a contract position, the budget amendment recommends adding an unclassified state dental officer position starting July 1st, 2021, and associated operated costs with personnel costs funded with approximately 75% federal funds and 25% general funds at a total cost of $481,016, of which $130,833 is general fund and $350,183 is federal funds, which is a total of $8,388 less than the original recommendation, a decrease in general funds of $113,869. According to the agency, adding the position of state staff as opposed to a contractor enables the receipt of 75% federal matching funds rather than 50% as is typical for administrative costs. The recommended annual salary for the position is $175,191 per year, which is equivalent to a senior physician range C. The final salary of the position will be determined when the pay bill is considered. For background regarding this position, the 2001 legislature approved establishing a state dental health officer position that must be a licensed dentist appointed by the Division of Public and Behavioral Health. From 2016 through 2020, the state dental health officer position was funded in the Public and Behavioral Health chronic disease budget through fee-generated reserve funds transferred from the radiation control budget. Considering decreasing reserves within that budget during the 2019 session, the funding mechanism was approved for FY20, and money committees issued a letter of intent directing the agency to identify a different funding source beyond fiscal year 2020 if it wished to retain the position. In the agency's letter of intent response, it indicated moving the position to healthcare financing and policy was being considered, noting that such a move would require a statutory change. In fiscal year 2021, the position was funded through a work program using tobacco settlement funds, maternal child health federal block grant funds, and a communicable disease budget HIV prevention grant. The agency seeks to locate the position within healthcare financing and policy to provide a sustainable funding source and to strengthen the clinical expertise of the Medicaid program. The agency indicates the position would oversee the Medicaid Dental Benefits Administrator, Liberty Dental Plan, provide clinical oversight and policy support for Medicaid dental services, provide Medicaid-related education pertaining to oral health, and support the division's efforts to develop a waiver to provide dental coverage to adults with diabetes pursuant to NRS 422-27247. During the budget hearing, the agency indicated that having a position dedicated to dental health would help ensure its dental policies were aligned with the most effective clinical services. The duties of the state dental health officer are laid out in NRS 439272, and they relate to determining the needs of the residents of the state regarding public dental health, providing advice regarding dental health to the Advisory Committee on State Program for Oral Health, as well as the Division of Public and Behavioral Health, and make recommendations to the Advisory Committee, the Division of Public and Behavioral Health, and the legislature regarding programs in the state for dental health. Although a bill draft was not submitted to support this recommendation, considering the statute requires the position to be appointed by the Public and Behavioral Health Division rather than Division of Healthcare Financing and Policy, it would be appropriate to amend statute to locate the position within the DHCFP, and the agency has indicated this would be appropriate. Therefore, if the subcommittee wishes to recommend approval of the new unclassified position, it may also wish to request a bill draft to place the position within the Division of Healthcare Financing and Policy. The next position change relates to a Medicaid pharmacy advisor position. The governor recommends transferring in $440,000 approximately for one unclassified senior physician and associated operating costs from the Northern Nevada Adult Mental Health Services budget to serve as a Medicaid pharmacy advisor to provide clinical expertise regarding prescription drug benefits. And this position, as recommended, is funded with a 50-50 general fund, federal fund split. The position is currently filled, and the incumbent would transfer over to the Division of Healthcare Financing and Policy. The agency indicates the position would serve as an advisor to the Drug Use Review Board and the Silver State Scripts Board, review pharmacy utilization data to target areas for efficiencies, provide oversight to the pharmacy benefit manager contract, advise the division on general pharmacy issues, as well as lead the department's efforts to lower overall cost of prescription drugs within the state. Regarding funding, as previously discussed with the state dental officer, federal regulations do allow for a 75% federal match for skilled medical professionals. and staff has completed technical adjustments to reflect this 75% federal funding, which would increase general fund savings by about $109,326 when compared to the governor's recommended budget. Regarding the addition of the state dental officer and senior pharmacy advisor position, while the division currently has a number of healthcare coordinator nurse positions that serve in various policy and oversight roles, it does not currently have other high-level licensed medical professionals on staff, and the agency indicates it would benefit from increased clinical expertise in developing policy for the Medicaid and checkup programs by ensuring programs are evidence-based and aligned with the most recent clinical guidelines. The final position change relates to one new start October 1st, 2021.
Ms. Crockett, I hate to interrupt you, but we lost you for just a second. Could you just go back maybe 3 or 4 sentences ago?
Would you like me to start with a data quality position?
That would be perfect. Thank you.
Or, okay. The governor recommends one new business process analyst to support data quality initiatives for federal reporting at a cost of $142,925 with a 10% general fund match. The position would work on data quality initiatives related to reporting for the transformed Medicaid statistical information system, which is a federal reporting system. The agency indicates an expansion of data elements in recent years has led to the need for additional resources to maintain compliance with federal requirements. The agency indicates it is currently complying with requirements, and it has identified approximately 68 data quality issues waiting to be resolved, most of which relate to encounter data received from the managed care organizations. Accuracy in this data is critical as it is utilized to develop the per person per month capitated rates paid to the managed care organizations. If the federal government were to determine the state was not meeting data quality standards, the agency indicates it would have to submit a plan to address issues. If issues were not addressed within 6 months, the agency would be at risk of decreased federal matching funds for its Medicaid management information system, decreasing from 75% to 50% matching. There are 3 separate decisions for the subcommittee. Would you like me to pause after each one, Madam Chair, or would you like to consider one motion for these 3 position changes?
I believe on this one we can consider one motion on all 3.
Okay. The first decision is, does the subcommittee wish to recommend approval of budget amendment A215083158 to add one unclassified state dental officer position and associated operating travel and equipment costs at a total cost of $481,016, $130,833 general fund, and $350,183 federal funds over the biennium, with the understanding that the final salary of the state dental officer position would be determined by the money committees with the pay bill is considered, with authority for technical adjustments and to request a bill draft to locate the position under the Division of Healthcare Financing and Policy rather than the Division of Public and Behavioral Health. The second decision, does the subcommittee wish to recommend approval of transferring in one unclassified senior physician and associated operating costs from the Northern Nevada Adult Mental Health Services budget to serve as the Medicaid pharmacy advisor, with technical adjustments to fund the position with 75% federal funds and 25% general funds at a total cost of $440,613, of which $110,980 would be general funds. And does the subcommittee wish to recommend approval of one new business process analyst and associated operating and equipment costs to support data quality initiatives for federal reporting at a cost of $142,925, of which $14,293 would be general fund over the upcoming biennium?
Thank you, Ms. Crockett. Members, any questions? Seeing none, I'll move for the motion.
Thank you, Chair. I would move to accept the motion as described by staff on pages 8 and top of 9.
And second on the motion? It's been moved in second. Any discussion on the motion? Seeing none, all in favor, say aye. Aye. Any opposed? The motion carries with the members present. We can move on. Thank you.
Thank you, Madam Chair. The next issue relates to pharmacy benefit manager contract and status of pharmacy benefits. The governor recommends total funding of $8.1 million, including $2.6 million in FY 2022 and $5.5 million in FY 2023 to support increased costs associated with the agency's pharmacy benefit manager contract. Currently, the managed care organizations, MCOs, administer prescription drug benefits for those participants enrolled in an MCO, and the agency's fiscal agent subcontracts with a pharmacy benefit manager for those enrolled in fee-for-service. The agency seeks to enter into a direct contract with a pharmacy benefits manager for improved compliance and transparency purposes. The existing contract expires June 30th, 2020, and the agency plans to release its request for proposal and award the contract in June 2021 to allow for a one-year implementation timeframe. At the December 18th, 2020 meeting of the Interim Finance Committee, a contract was approved for a contractor to assist with the development of the request for proposals for the contract with the pharmacy benefit manager. In response to questions by fiscal staff in preparation for the meeting, the agency indicated it was intending to carve out pharmacy benefits from the MCO contracts with the implementation of the new direct pharmacy benefit manager contract. Under a carve-out model, capitation payments to the MCOs would decrease, replaced with payments to the pharmacy benefit manager, which could lead to a decrease in the insurance premium tax revenue deposited into the general fund, estimated at roughly $9.4 million per year. However, during the meeting, the agency did not confirm its intent to carve out pharmacy benefits. In response to questions regarding the governor's recommended budget, the agency indicated its initial intent was to carve out these benefits effective July 2022. However, in recognition of loss of the insurance premium tax revenue associated with the policy change, the agency now seeks to further analyze the total fiscal impact to the state, including savings associated with improved management of prescription drugs and increased drug rebate revenue before moving forward. During the budget hearing, the agency indicated it does not intend to move forward with carving out prescription drug benefits during the upcoming biennium. However, the subcommittee expressed concern that the agency would be able to move forward with such a change without legislative approval if federal approval were sought and granted during the interim. Accordingly, the subcommittee may wish to recommend approval of language in the Appropriations and Authorizations Act, directing the agency to continue with the existing prescription drug benefit delivery model for the 2021 to 23 biennium. The decision for the subcommittee, does the subcommittee wish to recommend approval of $8.1 million, including $1.6 million in general funds, over the upcoming biennium to support costs associated with the contract pharmacy benefit manager? And does the subcommittee wish to recommend approval of language in the Appropriations and Authorizations Act, directing that funding approved for the Medicaid and checkup budgets be expended to continue the current service delivery model for prescription drugs, in which prescription drugs are generally not carved out from managed care in the 21 to 23 biennium?
Thank you so much, Ms. Crockett. Any questions for members? Seeing none, I will accept a motion.
Move as described by staff on top of page 10.
May I get a second? Second. It's been moved by Senator Ratty and seconded by Assemblywoman Carlton. Any discussion on the motion? Seeing none, all in favor of the motion, please say aye. Aye. Any opposed? The motion carries with the members present. Moving on.
The final major closing issue in this budget relates to information technology projects. The governor recommends $4.4 million, including $759,696 in general fund for 4 IT projects, and an additional budget amendment was submitted for a 5th project. The first project relates to continuing the implementation of the electronic visit verification system, decision unit M518, at a cost of $1.4 million over the biennium. This is a vendor-operated system that involves recipients providing electronic verification, such as through a web portal. The services were provided prior to the agency processing payments to providers. The agency indicates that the implementation of this system is intended to improve program integrity, reduce billing errors, and prevent fraud, waste, and review abuse. And this system is being implemented in response to a federal mandate. The system was initially approved to be implemented in December 2018. And the request for the upcoming biennium would fund the addition of home health services, which is a federally required component of the program. There will be ongoing costs associated with operating this system in the future, estimated at about $922,000 annually. During the budget hearing, the agency indicated to date it has not identified any programmatic efficiencies or necessary policy changes following the initial deployment of the system, but in the future, it may identify such changes as it gathers additional data. The next decision unit, M517, relates to an initiative to improve patient access to healthcare. The governor recommends $2 million over the biennium for costs associated with providing application programming interfaces as a means of providing participants with access to healthcare data, which is also a federally mandated project. This would result in a mobile digital platform which would allow participants to access claims, clinical data, appointment scheduling, as well as an electronic Medicaid card. The agency indicates there may be future cost reductions associated with reduced printing and mailing. The next project, E225, relates to health information exchange projects. The governor has recommended $1 million with the state share provided through donations rather than general fund in FY 2022 to support underserved facilities and provider offices with connecting to Healthy Nevada statewide health information exchange. On April 2nd, 2021, the agency's request for federal funding in support of this project was denied by the Center for Medicare and Medicaid Services, as the donation was deemed to be an impermissible source of funding for the non-federal share of project costs. As federal funding for the project is not authorized, the agency indicates this decision unit should not be approved. Next decision unit, E226, relates to the Medicaid Management Information System modernization. The governor recommends $42,000 in FY 2022 to support costs to complete the modernization project. This was initially implemented in the 2007-09 biennium, and this is the final closeout phase of that project. No costs are anticipated in the upcoming or beyond the upcoming biennium for the modernization project. On March 28th, 2021, Budget Amendment A215003158 was submitted to provide $158,440, funded with 90% federal funds and 10%, or approximately $16,000 in general funds in FY 2022 for a contractor to perform IT-related tasks required by CMS, including an environmental scan of the state's current health IT landscape, updating the agency's health IT roadmap and plan. The agency anticipates the work will be complete by March 2022. This budget amendment was not previously discussed at the budget hearing, and the agency indicates the project was omitted from the agency's budget request due to an oversight. The decision for the committee. Does the subcommittee wish to recommend approval of 4 IT projects, including decision units M517, M518, E226, and budget amendment A215003158 at a total cost of $3.5 million, of which approximately $775,000 would be general fund over the upcoming biennium, and disapproval of decision unit E225 as CMS did not approve federal funding for this project.
Thank you so much. We have questions. I have a question from Assemblywoman Titus.
Thank you, Madam Chair. So going back to decision in E225, is there some, I think that project I think is very important and in the long run, again, helps providers who see Medicaid patients, and with that communication and in the long run, perhaps indeed saves some money, not repeating tests, able to exchange some of that needed information. Is there some alternative thing that the agency has looked at since CMS denied that? And I understand that we wouldn't want to commit, we can't commit federal funds, obviously, but have they thought of an alternative?
Staff is not aware of any alternatives that have been considered by the agency. My understanding,
Great.
based on the letter from CMS, is this particular project was denied because it appeared the donation was coming from an entity that would be the direct beneficiary of the increased
okay.
federal fund,
Okay.
deemed to be impermissible.
All right, great. Thank you for that clarification. Thank you, Madam Chair.
Thank you. Senator Kiefer.
Thank you, Madam Chair, and I appreciate it. This is the first time I'm hearing about it. I believe that the HIE is resubmitting its application, and I agree with Dr. Titus that I think that the Health Information Exchange provides a really important service. There are no general funds in this. Is there a way to sort of authorize a contingent on federal funds getting approved or something to that effect, so that if they're able to get this process, that they would be able to move forward with the project? That might be a question to Ms. Crockett.
Staff would note that these types of projects are funded with 90% federal funds, 10% non-federal match. So if a donation was not available, then perhaps general fund would need to be used for the non-federal share. If the agency was able to identify an additional funding source for the non-federal share, perhaps during the interim, a different donation or something of that nature that was deemed to be appropriate by the federal government, processing would always be an option.
And that was going to be my question. So if they are able to get it squared away, going through the IFC work program process would be an option for drawing down the federal funds, accepting a donation, and moving forward with the project?
Yes, that's correct.
Senator Reddy.
Thank you, Chair. So I just want to make sure that we have clarity on this one. So sounds like what I heard was that there's potential that a different donor that doesn't have a direct benefit might be accepted by CMS. The agency is perhaps looking into that. But then I think what I heard the answer is based on the authority that Medicaid already has. If they are able to secure a donor, they are able to secure the CMS approval, they could come back through an IFC work program to ask to accept the donation and ask to accept the federal match. But there's no general fund dollars included in this discussion.
Yes, that's a correct summary.
Okay. All right, so it doesn't sound like we need to take any action on that. Are you ready for a motion, Chair?
I am.
Fantastic. So I'll go ahead and read this one. We wish to recommend approval of 4 IT projects, including decision units M517, M518, E226, and budget amendment A215003-158 at a total cost of $3.5 million, $775,540,000 in general funds over the 21-23 biennium, and disapproval of decision unit E225 as CMS did not approve federal funding for the project.
Thank you so much for the motion. Can I get a second? Second. It's been moved by Senator Ratty and seconded by Assemblywoman Carlton. Any discussion on the motion? Seeing none, all in favor of the motion, please say aye. Aye. Any opposed? Motion carries unanimously of the members present. We'll move on to the final closing item in this budget.
There are several other closing items. Staff recommends other closing items 1 through 5 be closed as recommended by the governor. And other closing items 6 through 9 be closed with noted technical adjustments with authority for staff to make further necessary technical adjustments.
Senator Reddy, can I get a motion?
Absolutely. Recommend other closing items 1 through 5 be closed as recommended by the governor, and other clothing items, not clothing, it's closing items 6 through 9 be closed with the noted technical adjustments with authority for staff to make further necessary technical adjustments.
By Assemblywoman Carlton, any discussion on the motion? Seeing none, all in favor of the motion, please say aye. Aye. Any opposed? Seeing none in opposition, the motion moves unanimously of the members present. Moving on to our next budget.
The next budget is the Medicaid budget. There are 8 major closing issues within this budget. The first closing issue relates to federal medical assistance percentage FMAP rates. The governor has recommended updating FMAP rates based on projected changes in these rates. The federal government pays states for a specified percentage of Medicaid and checkup program expenditures, referred to as the FMAP rates. The remaining portion of program costs must be paid by some other funding source, such as general fund appropriations or transfers from local governments. Variations in FMAP rates, which are revised by the Federal Centers for Medicare and Medicaid Services, or CMS, each federal fiscal year, have a material impact on the amount of general fund appropriations required to support the division's budgets. All decision units in the budgets are calculated using updated FMAP rates. The budget does not include separate decision unit that quantifies the general fund impact of FMAP rate changes. Information on final and estimated FMAP rates for each federal fiscal year is provided by the Federal Funds Information for States, which is used by the Governor's Finance Office and fiscal staff in constructing and reviewing the budget. The Federal Funds Information for States released information on the final federal fiscal year 2022 FMAP rates in September 2020, which are included in the executive budget and was initially anticipated to provide federal fiscal year 2023 projected FMAP rates in March 2021. With limited exceptions, the FMAP rate used to determine the funding split of program expenditures is based on the eligibility group of the participant. The standard FMAP rate for each state is determined annually based on the per capita income of the state relative to the per capita income of other states, with a floor of 50%. The Affordable Care Act provided 100% federal funding for costs of participants covered under the Medicaid expansion group, known as the newly eligible FMAP, from 2014 through 2016. Beginning in 2017, the FMAP rate for this population gradually began decreasing until it reached 90% in 2020, where it will remain. A temporary 23 percentage point increase in the Enhanced Children's Health Insurance Program CHIP FMAP rate was in effect from October 1st, 2015 through September 30th, 2020. There's a table in the packet on page 20 that displays the FMAP type with the related eligibility group. The Federal Families First Coronavirus Response Act, passed on March 18, 2020, authorizes a temporary 6.2 percentage point increase in the standard FMAP rate for quarters in which a public health emergency is in effect, as declared by the federal government. The calculation of the enhanced CHIP FMAP rate is based on the standard FMAP rate, and this temporary increase leads to a 4.34 percentage point increase in the CHIP enhanced FMAP rate. A temporary increase does not apply to the newly eligible FMAP rate. Regarding 2022 FMAP rates, the executive budget recommends FMAP rates for the upcoming biennium, assuming the expiration of the temporary FMAP rate increase on June 30th, 2021, based on existing public health emergency declarations. At the time the budget was prepared, a public health emergency has been in effect since January 20th, most recently on April 15th, 2021. The federal government extended the public health emergency through July 20th, meaning the temporary increase in FMAP rates would be available through September 30th of 2021. Additionally, in a January 22nd, 2021 letter to state governors, The acting secretary of the Federal Department of Health and Human Services indicated the public health emergency would likely remain in place for the entirety of 2021, meaning the temporary increase in FMAP rates may be available through December 31st, 2021. Additionally, the federal government could choose to continue the public health emergency beyond this point, which would provide increased federal funding for quarters in which the public health emergency remains in effect. Based on the letter from the federal government during the April 15th work session, the subcommittee discussed potentially budgeting for the temporary increase in FMAP rates through December 31st, 2021. The agency indicated it had asked other Medicaid agencies in other states whether these other states were budgeting for the temporary increase through December 31st, 2021. And they indicated 8 of the 10 states, or 80% that responded to them, indicated they were budgeting for this increase through the remainder of the calendar year. Based on the Biden administration letter to state governors, the subcommittee expressed an interest in budgeting the 6.2 percentage point temporary increase through December 31st, 2021. Accordingly, the agency provided updated revenue allocations between general funds and federal funds based on the temporary increase applying through that point in time. These rates are applied to the base budgets and decision units throughout the division's budgets. There's a table on page 21 that compares the governor's recommended blended rates, and those blended rates convert the federal fiscal year rates to state fiscal year for budgeting purposes. Assuming the continuation of the temporary increase in rates through December 31st, 2021 for the standard FMAP rate, that would be a 3.1% increase. For the enhanced CHIP FMAP rate, it would be a 2.17% increase. Regarding the FY 2023 FMAP rates, typically the federal funds information for states would release the federal fiscal year 23 rates in late March. However, this year the release was delayed due to timing of the decennial census data being released by the federal government. The official FMAP rates for the federal fiscal year 2023 will be released in fall 2021. And federal funds information for the states indicated it anticipates significant revisions to data that affects FMAP rates at that time due to COVID-related changes in personal income, meaning that the federal fiscal year 2023 rates may vary materially from the projections. At the work session, the Department of Health and Human Services had provided an estimated FY23 blended rate based on information available at that time. However, on May 6, 2021, federal funds information for states released their estimated FMAP rate projections, and they were lower than the department's initial estimates, with a standard FY 2023 rate of 62.68% and an enhanced CHIP FMAP rate of 73.88%, which was 0.22% lower than the agency's initial estimates. And the agency provided revised revenue allocations based on these updated projections. There's a table on page 22 that displays the governor's recommended and the most recent updated projections for the FMAP rates. There are material impacts, as previously mentioned, to general funds required to support the Medicaid budget based on fluctuations in the FMAP rates. There's a table on page 22 that displays fiscal staff's estimated difference in the base budget. In FY 2022, the increase in the rates results in about a $56.7 million savings in general fund. And in FY 2023, the decreased rate compared to the governor's recommended budget results in about a $19.2 million general fund increase. In total, the FMAP rate changes result in about a $37.4 million general fund savings over the upcoming biennium. There is more uncertainty surrounding projected FMAP rates than is typical during legislative session, as a temporary increase in the rate may be extended and the FY 2023 rates may vary materially from the initial projections Due to this uncertainty and the material general fund impact rates have on the agency's budget, the subcommittee may wish to consider recommending approval of one-time language in the 2021 Authorizations Act, authorizing the agency to accept additional federal funds in FY 2022 and FY 2023 to support the Medicaid and checkup budgets without requiring an offsetting decrease in general fund appropriations similar to authority provided for the current biennium through Assembly Bill 3 of the special session. This authority would allow the agency to retain general funds to support increases in caseload or other costs, such as increases in the cost per eligible or an FY 2023 decrease in the FMAP rate, for example, with any surplus general funds reverting at the end of FY 2023. The decision for the subcommittee: does the subcommittee wish to recommend approval of updated FMAP rates, including a temporary 6.2 percentage point increase in the standard rate through December 31st, 2021, which assumes a public health emergency will continue through December 31st, 2021 for FY 2022, and approval of the FY 23 rates based on the May 6 federal funds information for states projection? And does the subcommittee wish to approve one-time language in the Authorizations Act authorizing the agency to accept additional federal funds in FY 2022 and 2023 in the Medicaid and checkup budgets without requiring an offsetting decrease to general funds?
Thank you so much, Ms. Crockett. Members, are there any questions about the updated FMAP rate or the one-time language for the Authorizations Act? Senator Kekeffer.
Thank you, Madam Chair. I think that additional language in the Authorizations Act is both prudent and probably really important. I'm really concerned about what's going to happen with our 2023 FMAP rate, with all the money just getting pumped into the state through the federal government, and that's going to have downward pressure potentially on our 2023 rate. So I think it would make sense to give this sort of flexibility to the department.
Thank you so much for the comments. Any other questions or comments? Seeing none, Senator Reddy.
With pleasure, I will make the motion to accept the recommendation on the bottom of page 22 as described by staff.
Thank you so much for the motion. A second? Oh, yeah. It's been moved by Senator Ratty and enthusiastically seconded by Assemblywoman Carlton. Any discussion on the motion? Seeing none, all in favor, please say aye. Aye. Any opposed? The motion carries unanimously of the members present. Moving on to the next item.
The next item relates to Medicaid caseload, that is decision units M200 and M201. The governor's recommended funding totaling $630,152.5 million general fund in FY 2022 and $581.3 million, $144.5 million general fund in FY 2023 to support projected changes in Medicaid caseload. During the current biennium, actual Medicaid caseload has been higher than legislatively approved due to the economic situation in the state, with average monthly FY 21 caseload projected to be about 760,000, which is about 118,000 or 18.5% higher than legislatively approved caseload of approximately 640,000. In February 2020, caseload was in line with legislatively approved level at approximately 638,000. However, by October 2020, actual caseload had increased by 114,000 or approximately 18% to about 753,000. As with other departmental caseloads and consistent with previous legislative sessions, the agency provided updated March caseload projections based on February 2021 actual caseload and costs as prepared by the Department of Analytics. During the budget hearing, the agency testified the March caseload updates would be based on the public health emergency continuing through December 31st, 2021. There are several requirements for states to receive the temporary FMAP rate increase authorized through the Families First Coronavirus Response Act, including not terminating Medicaid enrollment unless an individual requests voluntary termination or ceases to be a state resident, referred to as the maintenance of effort or continuous eligibility requirement. Therefore, while the public health emergency is in effect, caseload will be higher as individuals are not disenrolled when they no longer meet standard program eligibility requirements, thus remaining on the caseload. The subcommittee expressed concern with the agency's planned reprojections and questioned the rationale for budgeting for the higher caseload without the accompanying increase in FMAP rate, recognizing that the higher caseload would increase costs, thus requiring additional general funds in the budget. During the April 15th, 2021 work session, the subcommittee expressed an interest in budgeting for the Medicaid caseload, assuming the public health emergency continues through December 31st, 2021, for consistency with budgeting for the temporary increase in the FMAP rates through the same date. With the public health emergency continuing through December 2021, economic recovery is expected to begin in the first quarter of 2022. However, employment numbers would not be projected to get back to pre-COVID levels during the upcoming biennium. The eligibility redetermination process would begin January 1st, 2022 and last approximately 6 months. A monthly average caseload would increase by about 25,000 from 822,000 in July 2021 to about 847,000 in December 2021. Then decrease by about 34,000 from January 2022 through December 2022 during the redetermination process, and gradually increase over the biennium to approximately 829,000 in June 2023. For context, the actual FY 2020 caseload monthly average was 651,760. Projected FY 2021 caseload is 771,560. Projected FY 2022 caseload is 831,224. And FY 2023 is 822,431. Compared to the caseload projections included in the governor's recommended budget, the largest increase in the most recent projections is in the newly eligible population, which covers childless adults with incomes up to 138% of the federal poverty level, with variances of about 16.9%, or about 47,000 participants in FY 2022, and 14.1%, or about 38,000 participants in 2023, as caseload for this population tends to fluctuate upwards as economic conditions deteriorate, and caseload would go downward as conditions improve, while caseloads for other populations, such as the medical assistants, the aged, blind, and disabled, tend to remain relatively stable as economic conditions change. And there's a table on page 25 that displays governor recommends and revised caseload projections by eligibility group. With regard to funding, the updated caseload projections increased total funding in the M200 and M201 decision units from $1.21 billion to $1.90 billion over the biennium, an increase of $683.8 million. General funds would increase from $297 to $320.5 million, which is a $23.5 million increase over the biennium. There is a table on page 25 that compares governor recommends to revised updated projections, both for both decision units. Does the subcommittee wish to recommend approval of updated caseload projections for the Medicaid program based on March 2021 projections, assuming the public health emergency continues through December 31st, 2021, funded with $1.01 billion, 152.9 million general fund, and $856.9 million in federal and other funds in FY 2022, and $886.1 million in FY 2023, comprised of $167.7 million general fund and $718.4 million in federal and other funds.
Thank you so much, Ms. Crockett. Members, any questions on the updated caseload projections for the Medicaid program? Seeing none, I'll entertain a motion.
I'd go ahead and make a motion to recommend approval of the updated caseload projections as described in the motion on page 25.
I have a motion from Senator Ratty, a second? A second from Assemblywoman Carlton. Any discussion on the motion? Seeing none, all in favor, please say aye. Aye. Any opposed? No opposition. That motion carries unanimously of the members present. Moving on to our third decision.
This item relates to a budget amendment and decision unit E678. On May 8th, 2021, the Governor's Finance Office submitted budget amendment A2168-13243. And regarding decision unit E678, the executive budget recommends using a $60 million projected FY21 surplus of state net benefit to offset general funds in this budget in FY 2022. The budget amendment was not previously discussed at the budget hearing. The budget amendment would recommend to rescind budget reductions approved during the 31st special session at a cost of $147 million, of which $74.5 million would be general fund in FY 2022, and $26.7 million, $7.3 million general fund in FY 2023. As mentioned, this budget amendment has not previously been heard by the subcommittee. In approving Assembly Bill 3, the legislature approved general fund reductions totaling about $134 million in this budget. And Section 31 of the bill outlines specific budget reduction measures to be implemented. The budget reduction measures status of implementing reductions and steps necessary to rescind the reductions would be as follows. First, reduction was reduce fee schedule provider rates by 6% and neonatal intensive care unit rates. As discussed during the budget hearing, the agency has not received federal approval to implement rate reductions for the majority of providers. The rate reduction has been federally approved for 2 providers, according to the agency, for waiver for frail elderly and waiver for physically disabled providers. Although most of the rate decreases have not yet been approved by CMS, the agency has incorporated savings associated with the rate reductions into the per participant per month capitation rates made to the managed care organizations effective January 1st, 2021. To restore this budget reduction, the agency would contact the CMS and withdraw its request to reduce the rates, and request that the rates for the 2 provider types for which reductions have already been approved be increased to the previous level effective July 1st, 2021, as rate increases cannot be retroactive according to the agency. The agency would also have its actuary recalculate managed care organization capitation rates and restore funding to the managed care organizations, with payments anticipated to be made by December 2021. The second budget reduction item was to eliminate a 2.5% acute care hospital rate increase approved through Senate Bill 528 of the 2019 session. The agency had not received CMS approval to implement the rate increase effective January 1st, 2021, as originally intended prior to the 31st special session. Therefore, it was not necessary to seek CMS approval to reduce this rate following the special session. If restoring the rate decrease is approved, the agency indicates it would not be able to implement this retroactively and would seek CMS approval to implement the 2.5% increase effective July 1st, 2021. The next budget reduction approved relates to revising the methodology for determining habilitation rates. As noted during the special session, this was a savings measure implemented in response to comply with federal guidance, and continued compliance is necessary. Therefore, this budget reduction measure should not be restored. The next item relates to a shift in non-capitated payments of the managed care organizations, laying certain payments from FY 2021 to FY 2022. The governor has already recommended reversing the savings measures and making these payments in FY 2021 in decision unit E690, which will be discussed later in this closing document. Therefore, no budgetary adjustment is necessary on this item. The final item was to implement a specialty pharmacy provider network. The agency indicates that it has not yet implemented this budget reduction measure. However, it continues to evaluate implementing this network and may seek to implement it in the future. As noted at the budget hearing, the governor's recommended budget did not include ongoing savings associated with implementing the specialty pharmacy provider network. Therefore, no budgetary adjustment on this item is needed. In decision unit E351, which will be discussed in the next major closing issue, the governor recommends restoring the 6% provider fee schedule rates increase effective October 1st, 2021. The budget amendment establishes a new E353 decision unit and recommends rescinding the 6% provider rate reduction effective fiscal year 2021, funded with a fiscal year 2021 budgetary surplus at an estimated cost of approximately $125.4 million, 27.7 million general fund to support the rate restoration July through September 2021. The budget amendment recommends rescinding the 2.5% acute care hospital rate reduction and increasing the rate effective July 1st, 2021. The budget amendment also recommends eliminating decision unit E678 and reducing the $60 million balance forward of state net benefit recommended in decision unit E678 to 19.9 million based on the current projected surplus to offset a portion of the cost of restoring provider rate reductions in FY 2022. Finally, there is a minor adjustment to correct a fund mapping error included in decision unit E351. There is a table on page 27 that displays the various components of the budget amendment and the costs associated with each component. The 6% provider fee rate restoration July through September comes at a total cost of about $74.6 million in FY 2022. The 2.5% acute care hospital rate restoration total cost is about $26.7 million in each fiscal year. The managed care organization provider rate restoration for the 6% rate reduction that has already been passed on to the managed care organizations would be at a total cost of $45.7 million in FY 2022. The state net benefit reduction requires additional general funds of $40.1 million in FY 2022, and the technical correction results in general fund savings of roughly $700,000 over the biennium. Fiscal staff notes that Section 31 of Assembly Bill 3 of the 31st Special Sessions specified budget reduction measures that are now recommended to be reversed. Accordingly, if the subcommittee wishes to recommend approval of the budget amendment, it should also recommend language in the Appropriations Act to amend Assembly Bill 3 to remove language directing the agency to implement budget reduction measures that would no longer take place. Companion budget amendments were also submitted for the checkup and intergovernmental transfer budgets. If the subcommittee wishes to approve this budget amendment, the companion budget amendments should also be approved. The decision for the subcommittee: does the subcommittee wish to recommend approval of budget amendment A216813243 to rescind budget reductions approved during the 31st special session, including the elimination of decision unit E678 at a cost of $147,074.5 million general funds in FY 2022 and $26.7 million, 7.3 million general funds in FY 2023, and recommend approval of language in the Appropriations Act to amend language in Assembly Bill 3 of the 31st special session to remove applicable language relating to the budget reductions.
Thank you so much, Ms. Crockett. This is a good day in HHS. I have no tears yet, so this is a really good day. Any questions on this decision before we go to the motion? Any questions? Assemblywoman Carlton, then we'll go to Senator Kekeffer.
And thank you, Madam Chair. So, I remember very distinctly that evening, as one of our colleagues said the other day, sitting in 4100 with our caucus, going through the list of these cuts and looking at the faces of some of the folks who had never faced something like this before, and the just they were deer in headlights. They were just in shock that we had to make these types of decisions and make these types of cuts. I wish they could be in the room right now to see us putting it back, but we'll make sure they know what's going on. We had the conversation in the special session. We realized what we had to do at that moment in time. We also made the commitment that as soon as we could fix this, we would. And we, as a body, are honoring that commitment today. We could have gone through this and picked and chose who we wanted to, especially in the fiscal situation that we are in right now. But we made the commitment that we would move forward on this when it was possible. And thank goodness we're able to do it today so that this can get addressed and move forward. And we future legislators can have the debate over NICU, ICU, all those different components of this bill. So thank you very much, Madam Chair.
Thank you. Senator Keycoffer.
Thank you, Madam Chair. So, Ms. Crockett, I want to clarify exactly what we're doing. So in the chart on page 27, it indicates the 6% rate reduction is being restored for the first, 3 months of the current fiscal year? Is that the way I'm reading that? Or I'm sorry, the next fiscal year, July 20, of the 2022 fiscal year.
Yes, the rates, budget reduction measures would be rescinded effective FY 2021, funded with a surplus in 2021. There were savings built into the FY 21 projections, assuming the savings would be realized. Those savings would be removed from the agency's budget, which the surplus, which was used as a budgetary savings measure in Decision Unit E678, which is being reversed. And then within the budget amendment, it would fund the first 3 months of the 6 rate restoration and a separate Decision Unit E351, which is in the next major closing issue, would fund the rate restoration for the remainder of the biennium.
So if the state plan amendment is withdrawn, the rates had not yet been approved by CMS for the reductions that had been approved during the special session, right? And the expectation was that we were going to ask all the providers to write us a big check for the reductions between whenever we approved it for August 1st or whatever it was through the end of the fiscal year. Is that being accommodated in the $40 million in state net benefit, or how is that being addressed?
That is being addressed in FY 21, and that does have the effect of reducing FY 2021 savings that would be available to support this budget in FY 2022. Initially, the governor had recommended $60 million to balance forward from FY 2021 to FY 2022. That has been reduced by $40 million, about $19 million. So that is essentially what the cost of restoring it in FY 2021 is.
Okay, so I'm reading that correctly. It's the state net benefit reduction of $40 million that is accommodating the sort of forgiveness, if you will, of the 6% rate cut that we had made during the special session that was effective in fiscal year 21.
Yes, you are correct, Senator.
Thank you very much. I wanted to make sure that was clear for everybody. And I certainly usually don't like getting budget amendments late, but this was an awfully good one. So thank you.
Senator Reddy.
Thank you, Chair. I did want to just get one piece on the record. So the process is, of course, we apply for this state plan amendment. That we are still in process for that state plan amendment, so that will be rescinded. But the way that the bulk of our Medicaid services are funded are through managed care organizations. And my understanding is that at least one managed care organization has already implemented some of these cuts. And so it would be then incumbent upon that managed care organization to work with the providers within their network to restore the cuts that they have already absorbed, those providers. Am I understanding this correctly?
Yes, you are correct. The managed care capitated rate have been decreased, and so part of the budget amendment would be to have their agency's actuary recalculate the rates as if the rate reduction had never taken place and make this managed care organization. Those are anticipated to be made by the end of this calendar year. With regard to rates paid by the managed care organizations to providers, the division's contract not allow the agency to directly control what rates are paid by the managed care organizations. So I do not believe there would be any guarantee that the managed care organizations would be required to reduce or restore their rates. Although the agency has indicated to me in the past, generally when changes are approved by the legislature, those tend to be passed through to the providers by the managed care organizations.
Okay. I just think it's really important that that be on the record. I hope that past practice proves to be future practice. But really what we'll be doing here is those who haven't taken cuts will not have to take cuts. Those who have taken cuts, we're going to make the managed care organization whole, and then hope that the managed care organization will make the providers whole. Thank you.
Thank you for getting that on the record. Any other questions before we go to the motion? Okay, seeing none, Senator Reddy.
All right, so I would wish to recommend the approval of Budget Amendment A216813243 to rescind budget reductions approved during the 31st special session, including the elimination of Decision Unit E678 at a cost of $147,074.5 million, which are general funds, in fiscal year '22, and $26.7 million, $3 million, which are general funds, in fiscal year 2023, and recommend approval of language in the Appropriation Act to amend language in Assembly Bill 3 of the 31st special session to remove applicable language relating to the budget reductions.
I have a motion from Senator Ratty, and a second from Assemblywoman Carlton. Any discussion on the motion? Seeing none, all in favor of the motion, please say aye. Aye. Any opposed? Motion carries of the members present. We'll move on to the fourth item in this budget.
Thank you, Madam Chair. Kathy Crockett for the record. The fourth item relates to provider reimbursement rate increases. The governor recommends funding totaling $368 million in FY 2022 and $571.2 million in FY 2023 for mandatory and discretionary reimbursement rate increases for providers. The first item is Decision Unit M101, mandatory rate increases. In the governor's recommended budget, managed care organization and dental capitation rates, along with provider rates for rural health and federally qualified health centers, Indian health services, and hospice services are recommended to increase by 3.52% in FY 2022 and 3.68% in FY 2023 based on projected inflation for medical care the agency obtained from Moody's Analytics in September 2020. Prescription drug costs were recommended to increase by 5.5% in each year of the upcoming biennium due to a typographical error. In March 2021 caseload projections, the agency updated inflation rates based on Moody's Analytics February 2021 projections, including prescription drug inflation of 2.71% in FY 2022 and 3.48% in FY 2023. And managed care organization, rural health center, federally qualified health center inflation of 2.76% in FY 2022 and 3.48% in FY 2023. As previously noted regarding prescription drug inflation, the executive budget had recommended a fee-for-service inflation for prescription drugs of 5.5%. However, there was an error, and the updated March 2021 projections correct the error. Projections from Moody Analytics have generally been used in Medicaid as well as the Public Employees Benefits Program and prison medical budgets to align medical inflation rates across the state. However, the 2009 legislature did approve a higher inflation rate for fee-for-service Medicaid prescription drugs based on the agency's concern that the Moody's analytic projection would be inadequate. Inflation for managed care organization prescription drug coverage is included in the managed care organization inflation, which is budgeted at the Moody's analytic rate for medical care. On March 29th, 2021, the agency sent a memo to fiscal staff and the governor's finance office expressing concern with the revised prescription drug inflation rate and requested a rate of 6.62% per year based on a 4-year average overall fee-for-service drug expenditures. The agency indicated the higher rate could account for increased utilization of certain high-cost drugs. However, projected changes in prescription drug utilization have not usually been budgeted for, as high-cost drugs are continually introduced, while patents on existing drugs also expire, enabling generics. Furthermore, difficulty in projecting utilization of high-cost drugs may be experienced. During the work session, the agency just indicated the 6.62% inflation rate was appropriate based on the recent cost increase as described. And they noted the introduction of a high-cost drug for spinal muscular atrophy was anticipated to increase prescription drug costs. However, cost increases in prescription drugs relating to utilization trend are separate from true inflationary cost increases and should be requested in a separate enhancement decision unit rather than combined in the federally mandated M101 decision unit. According to the agency, increasing the prescription drug inflation rate would require additional general funds of $12.6 million over the upcoming biennium. As an alternative to approving additional general funds to support the requested 6.62% inflation rate, as the request appears to be related to speculative changes in prescription drug utilization rather than true inflationary cost increases. The subcommittee may wish to consider providing the agency with a one-time authority to seek a supplemental appropriation during the 2023 legislative session if a shortfall results directly from higher than budgeted prescription drug costs. As outlined in the other closing items section of this document, with the exception of the administration budget, general funds appropriated to the division are limited to amounts included in the Appropriations Act, and the division shall not request an additional appropriation with certain exceptions that are laid out in the bill. To provide authority for the agency to request a supplemental appropriation, the subcommittee could recommend approval of language in the 2021 Appropriations Act authorizing an exception to the appropriations limit if the agency experiences a general fund shortfall that can be demonstrated to be caused by higher fee-for-service prescription drug costs when compared to budgeted amounts. Based on the March 2021 caseload projections and FMAP rate changes, the cost of the M101 decision unit has decreased from $502.7 million, $143.8 million general fund to $366.3 million, $106.6 million general fund over the biennium. The next item relates to discretionary rate increase at decision unit E351. As previously discussed, this would restore the 6% reduction in fee schedule reimbursement rates paid to providers approved during the 31st special session effective October 1st, 2021. Based on the March 2021 caseload projection and FMAP updates, the cost of this decision unit has increased from $436.5 million, $117.3 million general fund to $481.2 million, $126.8 million general fund over the biennium. There are 2 decisions for the subcommittee, and the first decision has 3 options. For decision unit M101, does the subcommittee wish to recommend approval of option A, approved decision unit M101 based on the March 2021 caseload and FMAP updates and Moody's Analytics inflationary rates, and do not provide authority for the agency to seek a supplemental appropriation if it experiences a general fund shortfall caused by prescription drug cost increases at a total cost of $366.3 million, $106.6 million general fund over the biennium. Option B, approve decision unit M101 based on the March 2021 caseload and FMAP updates and Moody's analytic inflationary rates, and provide approval for one-time authority for the agency to seek a supplemental appropriation if it experiences a general fund shortfall caused by prescription drug cost increases through one-time language in the 2021 Appropriations Act at a cost of $366.3 million, $106.6 million general fund over the biennium. Option C, approve decision unit M101 based on the March caseload and FMAP updates and Moody's Analytics inflationary rates at a cost of $366.3 million over the biennium, and also approve an additional $12.6 million in general fund over the biennium to support higher prescription drug inflation than projected by Moody's Analytics. And separately, decision unit E351. Does the subcommittee wish to recommend approval of funding to restore the 6% reduction in fee schedule rates effective October 1st, 2021, at a cost of $481.2 million, of which $126.8 million would be general fund?
Thank you. Members, any questions? I know where I am leaning and what I'll be asking for the motion for, but I'm going to go to Assemblyman Roberts.
Thank you, Madam Chair. And just a quick question. So, but on item C, so what if Moody's is off, and let's say the increase is actually more than 12.6 million? They would still have to come back for a supplemental appropriation anyhow? Is that correct?
Based on language in Appropriations Act, the agency is limited to general funds approved by the legislature. So if cost increases were beyond that, they would need to look at their program and possibly implement some sort of programmatic change. Stay within that general fund limit. The Appropriations Act does specify very certain circumstances in which the agency could seek a supplementation. So without language relating to cost increases, the agency would not be allowed to seek that. But there is nothing that would preclude the legislature from appropriating additional funding if it deemed necessary in the upcoming session.
So if you chose B and they were off, then we would be covered with B, correct? Because we're approving a supplemental if they come into trouble, right? Just so I understand the
Yes,
process.
that's correct.
Thank you. Thank you, Madam Chair.
Any other questions? All right, with that, I will ask for a motion for B on our direct decisions.
Absolutely, Chair. I appreciate the opportunity to work this through with Chairman Moreno. And obviously, this is a challenging budget to project because of the high-end prescription drugs that can swing it one way or another. So I appreciate the work that's been done. I appreciate the opportunity to work with the Chair on this and agree with her recommendation that B is the way to go. So the motion would be page 30, choosing and under decision unit M101, recommend the approval of item B, and decision unit E351, recommending approval to restore the 6% reduction fee as described on the bottom of page 30.
Thank you. We have a motion from Senator Ratty, a second from Assemblywoman Carlton. Any discussion on the motion? Seeing none, all in favor of the motion, please say aye. Aye. Any opposed? The motion carries with the members present. We will move on to the fifth item in this budget unit.
The fifth item relates to a budget reduction measures, service eliminations. As a cost-saving measure, the governor recommends eliminating basic skills training, psychosocial rehabilitation services, biofeedback and neurotherapy services, and behavioral health case management, effective January 2022, for savings totaling $22.4 million in FY 2022 and 48.2 million in FY 2023. States determine the type, amount, duration, and scope of services provided within federal guidelines. Federal law requires states to provide certain mandatory Medicaid benefits, allows states the choice of covering other optional benefits. And Nevada covers a number of these optional benefits that are considered to be cost effective. The governor has proposed eliminating several services that are considered optional under federal law as a budget reduction measure. According to the agency, recommended service eliminations were proposed following the review of services that have a higher denial rates for lack of medical necessity and are part of an overall plan to improve the standard of care for behavioral health services. Additionally, the services proposed for elimination are designed to be short-term and rehabilitative, but the agency believes they have been used by people who may be better served in some cases by long-term services at a higher level of care if clinically appropriate. The agency also indicated they reviewed services and determined those for elimination that were anticipated to have the least impact on participants to achieve targeted level of savings. The first item is Decision Unit E682, Basic Skills Training. These are services which are intended to reduce cognitive and behavioral impairments and restore individuals to their highest level of functioning through positive reinforcement, modeling, operant conditioning, and other training techniques. And this would result in a savings of 11.7 million, 3.8 million general fund based on the updated March projections. The agency reports in fiscal year 2020 as a reference point for the subcommittee, approximately 3,349 individuals utilize these services. The agency indicates elimination of this service may cause issues with continuity of care and individuals reaching their highest level of functioning, although other behavioral health services would continue to remain available. Decision Unit E683, Behavioral Health Case Management, which are services that assist an individual in gaining access to needed medical, social, educational, and other supportive services for non-seriously mentally ill and non-seriously emotionally disturbed populations, is recommended for elimination for savings of 2.9 million, of which approximately 478,000 would be general fund based on the updated projections. The agency indicates the populations for which services would be eliminated have a lower level of care based on an intensity of needs evaluation tool. Case management services include assessment, care planning, referral, and monitoring, and do not include the direct delivery of medical services. Services are intended to improve behavioral health conditions by assisting individuals with accessing other services they need. If services were eliminated, the agency indicates participant may experience difficulty in identifying and accessing needed services. The agency reports 4,160 individuals utilize these services in FY 2020. Various other participant groups would continue to have access to services, including children and adults, or children and adolescents who are seriously emotionally disturbed, adults who are seriously mentally ill, persons with intellectual disabilities and related conditions, developmentally delayed infants and toddlers under the age of 3, the juvenile parole population, the juvenile probation population, and child protective services. At the budget hearing, the agency indicated it has identified 2 groups for possible expansion of case management to be provided by county agencies, including criminal justice involved adults and pregnant women, to expand services to these 2 groups. A state plan amendment and Medicaid service manual changes would need to be approved. As services would be provided by the county agencies, it would be anticipated local governments would provide the non-federal share of costs matched with federal funding from this budget. In Decision Unit E684, psychosocial rehabilitation services are recommended for elimination. And these are rehabilitative interventions designed to reduce psychosocial dysfunctions and restore individuals to their highest level of functioning. for savings of 18.8 million, of which 5.9 million would be general fund based on updated projections. Although narrative in the budget indicates the service would only be eliminated for adults in follow-up questions, the agency indicated it would be intended to eliminate for all ages. In FY 2020, approximately 4,500 individuals utilized this service. According to the agency, the elimination of the service may prevent individuals from reaching their highest level of functioning, although other services would remain available. In Decision Unit E685, biofeedback and neurotherapy services, which are therapies designed to help participants learn to control some bodily functions, such as heart rate, as a treatment for mental health disorders, is recommended for elimination for savings of 39.6 million, of which 12.9 million would be general fund based on updated projection. The agency indicates these services are not evidence-based and are not covered by many private insurances or other state Medicaid programs. In 2020, the agency indicates approximately 8,200 individuals utilize these services. And if the services are eliminated, the participants may experience difficulty in continuity of care, and they may require other behavioral health services. When asked if the elimination of basic skills training, psychosocial rehabilitation, biofeedback, neurotherapy, and case management is anticipated to increase the utilization of other services, the agency indicated that any impact is unknown at this time, and a transition to other services would likely be gradual, with changes being observed in the second year following service eliminations, perhaps. The agency noted other behavioral health services which may be clinically appropriate for participants receiving the eliminated services that participants may choose to access include peer support services, crisis intervention, mental health therapy, cognitive behavioral therapy, and other similar evidence-based services, partial hospitalization program, intensive outpatient program, alcohol and substance abuse treatment, day treatment, and medication management. There are 4 decision points for the subcommittee. Madam Chair, would you like me to read them all as one or pause after each for questions and discussion?
I think we can go ahead and read them all, and then we'll go to discussion after. Thank you.
Okay, the first decision, approve decision unit E682 to eliminate basic skills training for savings of 11.7 million, of which 3.8 million would be general fund and 8 million would be federal and other fund reduction. Decision unit E683 to eliminate behavioral health case management for certain participants for savings of 2.9 million, of which 478,508 would be general fund and 2.5 million in federal and other funds. Decision unit E684 to eliminate psychosocial rehabilitation services for savings totaling 18.8 million, of which 5.9 million would be general fund and 12.9 million would be federal and other fund. And decision unit E685, eliminate biofeedback and neurotherapy services for savings of 39.6 million, of which 12.8 million would be general fund and 26.7 million would be federal and other funds, as recommended by the governor, adjusted for March 2021 caseload projections and FMAP rate changes.
Thank you so much, Ms. Crockett. We have questions from the committee. I'll start with Assemblywoman Carlton.
And thank you, Madam Chairman. So we're in this opportune moment where typically if we were going to do some add backs, this would be the moment in time that we would have those conversations. So knowing that we have had previous conversations about a global discussion on add backs, that'll be more focused on the budgets that we've already closed, because we never want to go back and reopen them. Staff would kick us out of the building very happily if we did that. So being able to close these correctly so that we wouldn't have to do a larger add back later on, I think would be very appropriate at this time. So I would like to suggest to the committee for conversation that as far as add backs go, that we consider the basic skills training, the behavioral health case management, and the psychosocial rehabilitation services. I'm not suggesting E685 at this time. In reading some of the backup documents, I'm not sure we want to go there with this one at this moment, but I believe the other three that I've noted, we could have a conversation about adding those particular items back. So if you would consider that a conversation point, and we can go from there. Thank you, Madam Chair.
I think that's a great conversation point. Assemblywoman Tolles.
Yes, thank you, Chair. And I just wanted to say I expressed a lot of concerns and questions about these proposed eliminations, and I appreciate the Vice Chair's suggestion, and am in agreement with doing whatever we can to add those back. And I understand we can't perhaps do all of it today, but I am in support. Thank you.
Thank you. Senator Ratty?
Thank you, Chair. Yeah, I just want to emphasize, because I appreciate the discipline that this committee and other finance committees have executed through the entirety of the first 102 days of the session to make really challenging decisions on lots of different budgets. And we're changing things a little bit today by making a different decision, as the chair or vice chair described, in terms of timing. Also, on these particular budgets, when we're talking about Medicaid, the significant opportunity to draw down a federal match, in addition to the cuts in services, make these particularly compelling, I think, for folks, and particularly because we have some questions about whether the federal stimulus dollars can be used to do federal match. This also becomes a place where we want to focus some attention. I will just say that we've been working really hard to make progress on behavioral health, and to have to absorb significant behavioral health cuts would be challenging, I think, for the state. But would also emphasize we're at a place where we really don't know yet how much money we're going to have to do everything, and so we do still need to make difficult decisions. So while I don't really want to cut the biofeedback and neurotherapy, I can do it, services necessarily, because I have a concern about a relatively abrupt cutoff of services for folks who are receiving some behavioral health care. We still need to have discipline. We still need to make tough decisions. And I think this is a tough decision that I can definitely support, given where we are in the session. So with that, I think not accepting the recommendations on items 1, 2, and 3, and accepting the recommendation on 4 is a great path forward.
Senator Ratty, is that a motion?
I would recommend approval, I would make a motion to recommend approval of item 4.
And not approve item 1, 2, or 3.
Correct.
A second on that?
And that would include the caseload projections and the FMAP changes. So with that, I would second.
Agree, that is a good clarification on the motion.
It's been moved by Senator Ratty, second by Assemblywoman Carlton, that we not approve item 1, 2, or 3, approve item 4, and as recommended by the governor with the adjusted for March 2021 caseload projections. Any discussion on the motion? Seeing none, all in favor of the motion, please say aye. Aye. Any opposed? The motion carries. Moving on.
The next item relates to budget reductions, savings measures to achieve savings of $182 million, of which 37.8 million would be general fund in FY 2022 and 16.8 million, of which 5.1 million would be general fund in FY 2023. The governor recommends several cost-saving measures, including using a projected FY 2021 surplus to pay certain managed care organization costs in FY 2021 rather than FY 2022. Implementing personal care services policy changes, reducing non-emergency transportation monthly capitated payments and implementing a two-sided risk corridor. The first savings measure relates to managed care organization payments in decision units E689 and E690 for FY 2022 savings of $168.5 million, including $31.6 million in general fund based on updated FMAP rates. The governor recommends making certain payment to the NCOs in fiscal year 2021 rather than 2022, including reversing the delay of payments to the NCOs related to certain maternity cases and very low birth weight newborns and stop loss reinsurance payments when certain costs of a participant exceed a $100,000 annual threshold from FY 21 to FY 2022 as approved in Assembly Bill 3 of the 31st special session. So that would be reversing that decision and paying projected July 2021 capitated payments for the newly eligible population in FY 2021 instead of FY 2022. These recommendations shift costs from fiscal year to fiscal year and do not represent an overall savings to the state. The agency would support these two savings measures in FY 2021 with a projected general fund surplus in this budget, currently projected at $79.2 million, according to the most recent projections based on actual caseload and costs. Recommendations noted previously would utilize $31.6 million, leaving 47.6 remaining, which would be used to support costs associated with the budget amendment as previously discussed. The next cost saving measure relates to personal care service policy changes in decision unit E687. The governor recommends implementing policy changes for personal care services, which enable participants to live independently in their homes by providing assistance with activities such as bathing, toileting, transitioning non-ambulatory individuals, mobility, eating, meal preparation, laundry, light housekeeping, and essential shopping, effective January 2022, based on updated projections. Savings total $23.9 million, of which $7 million is general fund over the biennium. Although backup documentation attached to the budget indicates services would be eliminated for participants with a live-in caregiver, the agency clarified that the intended policy changes would limit services that support what are considered instrumental activities of daily living that support independent living, such as housekeeping and assistance with chores and food preparation when a participant has a live-in caregiver. Services for activities which are considered daily living, such as bathing and eating, would not be modified. According to the agency, a functional assessment completed by a physical or occupational therapist places participants into 4 categories for activities of daily living. 0 would be independent, 1 would be minimum assistance required, 2 would be moderate assistance, and 3 maximum assistance. Certain services would be eliminated or reduced based on an individual's functional score for participants with a living caregiver. The policy changes for meal assistance would be eliminated for participants with a score of 1. And time for housekeeping and laundry assistance would be eliminated for participants with scores of 1 or 2, with 30 minutes a week authorized based on functional need compared to the 45 minutes per week currently authorized. Decision unit E686 relates to savings in non-emergency transportation per month, per member per month capitated payments. The agency has indicated its existing contracts is expiring and it will be entering into a new contract with the same provider at a reduced rate. So there is no change in services. It is merely a reduced negotiated rate for savings of about $919,000 over the biennium, of which $243,000 approximately would be general fund based on updated caseload and FMAP. In Decision Unit E676, the governor recommends implementing a two-sided risk corridor for calendar year 2020, with savings associated with 2020 to be realized in FY 2022 due to utilization variability related to COVID-19 for the state and the MCOs. According to the agency, two-sided risk corridors are used for prospective payment models such as managed care as a means of recovering funding for situations that can be difficult to predict, such as pandemics. The CMS authorized implementation of a two-sided risk corridor for FY 2020 for the states and managed care organizations to share in the risk of the current situation. In the two-sided risk corridor, if the monthly capitation rates to managed care organizations were too high compared to actual costs incurred based on utilization, the state would recover funds from the managed care organizations. Conversely, if the rates were too low, the state would owe funds to the managed care organizations based on utilization. The most recent projection provided by the agency projects 3.3 million in savings, including 1.1 million of which is general fund. Based on the updated calculation, the agency estimates the state would receive funds from two managed care organizations, including Anthem, 2.6 million, and Silver Summit, 735,128 in FY 2022, based on the current estimates. There are 4 separate decisions for the subcommittee for these budget reduction measures. Item A, approved decision units E689 and E690 to make certain managed care organization payments in FY 2021 rather than FY 2022 for savings of 168.5 million, 31.6 million of which is general fund in FY 2022. Decision unit E687 for personal care service policy changes to reduce certain services to participants with a living caregiver for savings of 23.9 million, of which 7 million would be general fund over the upcoming biennium. Decision unit E686 to reduce per member per month payments to the non-emergency transportation provider for savings of 919,344, of which 243,034 would be general fund. And decision unit E676 for FY 2022 projected savings associated with a two-sided risk corridor for savings of 3.3 million, of which 1.1 million would be general fund in FY 2022.
Thank you so much. Members, questions? Assemblywoman Carlton?
Thank you very much, Madam Chairman. And it's taken me a while to wrap my brain around this two-sided risk corridor. And I think now that I've heard it for the third time, I think it's finally sinking in. I guess my concerns are, yes, the state could possibly use the term claw back some dollars. But my concern is that if the rates are the other way, then the state is on the hook for that amount. And if we look at the last year of folks being ill and in hospitals, and all those folks that we saw on ventilators and how it impacted all the hospitals, those costs, some of those folks were probably Medicaid patients and probably were in managed care if they were in Clark County. So with this two-sided risk corridor, the state could end up possibly having to cover some of those costs in the future, if I understand it correctly. And Ms. Crockett, when you need to stop me, stop me. So I'm just curious, the dollars that have come through the CARES Act and went directly to hospitals to help with some of these costs, if we had a two-sided risk corridor, would any of those reimbursements at the federal level offset any of those Medicaid dollars? I know this is a complicated puzzle, but I'm just trying to think. The thing about capitated rates is there's predictability for the state, and sometimes we win and sometimes we lose. All it takes is a couple $1 million babies, preemies at UMC, and you know, you've got your capitated rate back. You're in good shape. So I'm just concerned with this two-sided risk corridor that we're going to lose that predictability, especially when there has been so much healthcare cost in the rearview mirror behind us. And will this will apply retrospectively, or is this just prospectively?
My understanding is this particular proposal relates to calendar year 2020 only, with cost recovery in FY 2022. As it stands right now, from what I understand, this is not being recommended to be an annual ongoing item in the budget, although possibly the agency could consider looking at that, but as it stands at the moment, that is not the case. So this is a one-time item right now.
And thank you, Madam Chair. And I think that's where it took me a while to really figure out what this actually did. And I want to thank Ms. Crockett for making it so clear this last time around. And I apologize, I don't want to throw us off base, but you know, the whole reason behind capitated rates in managed care is so that the state has that predictability going forward. I'm just afraid by doing this for this 1 year in 2020, when we know what those hospitals look like, but then we also know on the other side that what the doctor's offices look like. People weren't going. There was this weird utilization roller coaster. You had hospital utilization at one level and primary care utilization at the other level. So I'm just concerned that for the cost of $1 million to the general fund, we could be opening ourselves up in this two-sided risk corridor to all these unforeseen charges that might be coming from all this intensive care and all this health care that happened over this last year in 2020. So I might be seeing, you know, things behind the bushes or whatever. I hate to see us give up that predictability. And I just wanted to make sure that we had a thorough conversation about it, Madam Chair. Thank you.
Thank you, Madam Chair. Any other questions? Assemblywoman Titus.
Thank you, Madam Chair. Just regarding what the chair commented about the unforeseen charges, just for clarification, and maybe Medicaid needs to clarify that we can't have unforeseen charges because there's a time on when somebody can bill for a charge on Medicaid. So could we see additional charges? And I just don't think that's, in my understanding, how Medicaid is billed and how it's reimbursed, and that you have a limited time. I know as a provider, if I didn't get our bills in after X date, we couldn't bill. So can somebody clarify that?
If we have someone from, if Ms. Crockett, if you don't have the answer to that question, I'll be happy to go to the department and have them answer the question.
I do know that the agency have billing timelines that are laid out in their Medicaid service manual. I can't recall off the top of my head what those billing timeframes are, but there is a limited period of time in which providers can submit bills. The agency would be able to speak more directly to the exact timeframes.
And I believe we have the agency joining us.
Yep.
Thank you.
Good morning. This is Cody Finney. Can you hear me?
We can, yes.
Thank you, Chairwoman. So Ms. Crockett is correct. We have a 90-day window for billing in Medicaid, and our managed care program tends to stay to that window as well. So there is a limited amount of time for timely billing for all of these costs. The purpose of the two-sided risk corridor is really to mitigate the risk both for the state and the managed care plans in these unpredictable events. And it is possible for that to fall on either side. It is set up so that both the state and the plans are at risk. And I'd invite our fiscal staff to add anything they feel is relevant if you're so inclined, Chair. Thank you so much.
Thank you, Chair, and thank you for the clarification.
Now we have another question. Stand by, don't go anywhere. Assemblywoman Carlton.
And thank you with that, Madam Chair. So with the conversation about this being retrospective, and being for billing for 2020, if we know where we are, why are we changing the game?
Thank you, Madam Chair, through you to Mrs. Carlton. So the risk corridor does take some extensive time to work through. Again, this is designed to make sure that we don't over or underpay. And at the time that we worked through this, there was a limited time from CMS for us to implement a risk corridor. And there was significant concern that we might end up overpaying significantly the managed care plans. So this is the one option that's available to us to make sure that that does not happen for the 2020 year, or did not happen, forgive me.
Well, this is getting, I feel like I've gone down a rabbit hole, Madam Chair. I'm really sorry. Because we shouldn't be doing this at a closing, this, and I apologize. I should have done this at the work session. I understand what we're trying to do, but I think we made a deal with the folks when they signed on to be Medicaid providers that they were going to get a certain rate. And good, bad, or ugly, that was the rate that it was going to be. And if we start, I just have concerns that we could be putting the state at risk. I understand wanting to claw back dollars, but then again, that's not part of the original deal we made with the Medicaid providers. So, thank you, Madam Chair.
Thank you. Senator Ratty.
So, and I apologize, but we've sort of opened this up, so now I have some clarifying questions, so thank you for the discretion. So, I guess, so my question, it only applies to 2020, and so the concept here is, certainly when you were having to do your budget back in September, and then the governor approving it in January, we were in the depths of the pandemic and the shutdown, and what we were seeing was increased utilization in certain settings because of COVID, but underutilization everywhere else in the healthcare system. People weren't going to doctors, people were canceling their optional surgeries, all of those things. And so the idea here is that because this situation was so unique, both for, and I want to say it's the managed care organizations, not so much the providers. This is a conversation between the state and the managed care organization, and does not get down to the provider level. The provider level still is going to get their reimbursement based on their contract with their MCO, or their payer source, I guess I should say. But the conversation between the MCO and the state on the capitation rate is that capitation rate that was negotiated in good faith with two parties pre-pandemic, before anybody could have anticipated anything that we've lived through for the last year and a half, didn't make sense anymore, and that the two-sided risk corridor was an opportunity for a true-up between both parties to say this is what the real costs were. And when we decided to lean into that, it was because we believed that there would be underutilization and that it would benefit the state. Is that an accurate description of what's happening? That's the way I'm understanding it.
Suzanne Bierman, Administrator DHCFP for the record. Senator Ratty, I agree with your summary, and also to the point of, as we've seen utilization trends come in the beginning, I think there was a lot of concern that we would be overpaying, and then with some additional utilization trends, the risk of not producing or these savings not materializing does look more likely now than it did when we first put our budget proposal forward, just based on changes in utilization patterns. If that helps, but I agree with your overall summary of the issue.
Ms. Bierman, I think we need to hear you say that last part again, because it was a little hard to hear.
I was just saying that, sorry about that. I agree with the way that you summarized it. I think you summarized the issue nicely. I just wanted to add that point about the changes in utilization and how over time, we think it's less likely based on some additional utilization trends we've seen that even for the end of 2020, that those savings would materialize as opposed to when we first put this budget concept forward.
All right, so the bottom line is where we are now is all the billings should be in, but it takes 2 years to sort of analyze it to decide if we can get that savings in 2022. But your bottom line is, as of today, you still think the state will be on the upside of a two-sided risk corridor based on the experience of the pandemic. That's your best estimate for today?
Today, we think it's less likely that the amount of savings that we predicted originally will materialize. So I think back to Assemblywoman Carlton's point, there is risk there, right? It's on each side. And originally, we thought the likelihood of us seeing savings would be a lot higher than we now think it is based on some of the trends that we've seen come in.
So then, bottom line, is it still worth doing?
I think it's less worth doing than originally based on an increased likelihood that these savings may not materialize for the state. I hope that helps.
Thank you, Madam Chair. And again, I really apologize. I can remember having my blood pressure go up when I was chairing and somebody did this, but, so I just want to put that on the record again. I have concerns. I trust the hairs on the back of my neck. You got to trust your gut on some things. When I hear it's, Ms. Bierman said there would be less opportunity now when this was originally proposed. I'm glad we're having the conversation. I have serious concerns for a $1 million add back, the possible risk to the state in one or two very complicated cases that could come back to us. And then I always go back to we had an agreement with these folks. We didn't know there was going to be a pandemic. They didn't know there was going to be a pandemic. There's cost and risks and everything that we do. If they come out a little bit ahead, that's one thing. Knowing full well that managed care has to put 80% into care and 20% off to the side. So we got to make the ACA stuff is overarching on it. I'm concerned that putting $1 million, putting $1 million on the line as a bet on this one may not be a very good bet for the state at this time. So that's where I would be leaning at this moment. Just trusting my gut. That's what it boils down to.
Senator Kiefer.
Thank you, Madam Chair. And so, Ms. Crockett, our notes on page 35 indicated that there are updated calculations right above the decision box, that the agency estimates the state would remit funds to 2 MCOs at those levels. Is that just net? What is the updated number that you project?
I would apologize for the typo. That would actually say the state should receive funds, not remit funds.
Okay. And then,
So we would anticipate Anthem 2.6 million and Silver Summit about 735,000 based on the agency's most recent projections.
and is that total? So the state's share, the state general fund benefit of that would be deducted by the FMAP match?
Yes, that's correct. So the net general fund savings would be 1.1 million of the total 3.3 million savings projected for FY 2022.
And how recent are those updated projections?
They were provided to March caseload projections and updated for the FMAP rate. So we initially received those in early April.
Okay, thank you. Madam Chair, when we're off the subject of the risk corridor, I have another question.
So, Ms. Crockett, just for clarification, you're saying that the statement above the box on page 35 should read that the state would receive funds, not remit funds. Is that correct?
Yes, that's correct. I apologize for the typo.
Thank you.
Madam Chair, the concerns are not founded, so.
So members, let's do it this way. We're going to do each item separately and vote on it separately instead of doing a group one. So, seeing no other questions,
Madam Chair, can I?
go
add
ahead
one,
on another item.
a separate issue. Thank you, Ms. Crockett. On the E 689, it looks like that's about 10 million in general fund, but about $100 million total. This is us paying the July capitation rate to the MCOs out of 2021 dollars, right?
Yes, that is correct for the newly eligible population. So that is 90% federal fund, 10% state general fund matching rate on that.
Okay, I appreciate that. I think that would have probably made sense when the budget was built, but that's us paying ongoing operating expenses with one-time money. So I'll probably vote against that one when we get to it on the as we move down the line. Thank you.
Members, any other questions on any of the other items before us, A through D? Senator Ratty.
Thank you, Chair, for the discussion. Just one that I'd like to get on the record on item C, where there's a reduction in the 919,000 with 243,000 of it being general fund. I just want to confirm that that is not a reduction in service level, but actually results from a renegotiation of the contract that lowered the rate.
Yes, that is correct. Would continue the same services that are currently being delivered, just at a slightly reduced negotiated rate.
Any other questions? Discussions? Okay, then Senator Ratty, we're going to do each item separately. And we will start with item A in our gray box on page 35.
Thank you. So on item A, I heard the concerns, but I actually think with the strangeness of all of the different funding sources that we're dealing with, that it still makes sense to do this. So I would make a motion to recommend decision units E689 and E690 to make certain managed care organization payments in fiscal year 21 rather than fiscal year 22 for savings of 168.5 million, 31.6 million in general fund in fiscal year 2022.
Thank you, Senator Reddy, for the motion. A second? Second from Assemblywoman Carlton. Any discussion on the motion? All right. All in favor of the motion, please say aye.
Aye.
Any opposed? Those that are in opposition, if you could raise your hand. I have Assemblyman Roberts, Assemblywoman Titus, Senator Kekeffer, Senator Hammond. And the motion does carry on both sides of the House, of the committee. So we'll move on to item B.
Thank you, Chair. This was another area where, kind of like our prior discussion, where this is a significant and critical Medicaid optional service that allows folks to stay in their home, and I think does warrant consideration for being added back. So I would make a motion not to approve Decision Unit 687, item number B on page 35.
Thank you for that motion. Second? Second. We have a motion from Senator Ratty, second from Assemblywoman Carlton. Any discussion on the motion? Yes, Assemblywoman Carlton.
And thank you, Madam Chair. This item hits people where they live, and I'm very glad we're able to do this at this time. It makes a difference in the quality of life for these folks and their families. Thank you.
Thank you. Seeing no other discussion, we have the motion and the second. All in favor of the motion, please say aye. Aye. Any opposed? The motion carries unanimously of the members present. Moving on to item C.
Thank you, Chair. I would make a motion to recommend Decision Unit E 686 to reduce per member per month capitated payments for non-emergency transportation services for savings of $919,344,243 and $34 worth, which is general fund over the 21-23 biennium.
Thank you for the motion and a second. Second. We have a motion from Senator Ratty, a second from Assemblywoman Carlton. Any discussion on the motion? Seeing none, all in favor of the motion, please say aye. Aye. Any opposed? Motion carries unanimously of the members present. Moving on to the last item on this budget item, item D.
Thank you, Chair. Unusually swung back and forth and changed my mind 3 times on this decision, but I'm going to go ahead and make a motion to accept Decision Unit E 676 for fiscal year 22 projected savings associated with the two-sided risk corridor and calendar year 2020 for savings of $3.3 million, $1.1 million of which would be general fund in fiscal year 2022.
I have a motion from Senator Ratty, a second from Assemblyman Watts. Any discussion on the motion? Seeing none, all in favor of the motion, please say aye. Aye. Any opposed? Nay. Please show Assemblywoman Carlton as a nay, and the motion does carry. Moving on.
The next item relates to increased waiver slots. The governor recommends increasing caseload slots for the 3 Medicaid home and community-based waiver programs to support projected demographic caseload growth and to reduce wait lists to those waiting 90 days for services. These services allow Medicaid participants that would otherwise likely be institutionalized to receive long-term care services in home and community settings. Federal regulations require that waiver services be a cost-neutral alternative to institutional care. The division has administrative authority, establishes policy, and makes payments for services for the waiver programs, while aging and disability services incurs personnel and operating costs associated with overseeing and operating the waiver programs. As with other caseloads, the agency provided updated caseload projections and updated FMAP rate projections consistent with Medicaid caseloads for the 3 waiver programs. Caseloads are also projected to be higher than recommended in the executive budget. Overall, by the end of the biennium, 7,397 waiver slots are projected, which is increase from the 7,237 projected in the executive budget. Based on the updated projections and FMAP rate changes, total funding is projected to be $55.2 million. 8.2 million of which is general fund, which is a $5 million increase from the $50.2 million overall funding recommended by the governor. Regarding caseload growth, the cost associated with the caseload growth requires additional funding of $6.3 million, $840,794 general fund in FY 2022. And $16.6 million, 2.7 of which would be general fund in FY 2023 to support projected caseload growth. With regard to waitlist reductions as separate enhancements, the governor recommends increasing waiver slots to reduce waitlists for clients waiting longer than 90 days for services. After adjusting for caseload updates, 11 million, 1.1 million in general fund is required in FY 2022. And 21.1 million in FY 2023, of which 3.6 million would be general fund. There is a table on page 37 that displays the projected June 2021 caseload, the caseload growth decision unit, the waitlist reduction decision unit, and the total projected caseload in June 2023 for each of the 3 waiver programs. Updated caseload projections align with projections approved in closing the Aging and Disability Services Division budgets on April 28, 2021. Fiscal staff recommends the subcommittee recommend approval of updated waiver caseloads consistent with its actions in closing the aging budgets. Does the subcommittee wish to recommend approval of waiver slot increases based on March 2021 projections and FMAP rates at a total cost of $55.2 million funded with $8.2 million in general fund, $4.7 million in county reimbursements, and $42.3 million in federal funds, consistent with its actions in closing the Aging and Disability Services Division budgets.
Thank you so much. Members, any questions? Seeing none, I will entertain a motion.
I would accept the motion as described, or I would make a motion to make the recommendation as described by staff on page 38.
A second?
For clarification, Madam Chair, there's a couple things on what page, 38?
38, yes, regarding, so I would amend that motion to be the approval of the waiver slot increases as described on page 38.
Thank you. Second.
I have a motion from Senator Ratty, a second from Assemblywoman Carlton. Any discussion on the motion? Seeing none, all in favor of the motion, please say aye. Aye. Any opposed? Motion carries with the members present. Moving on to the next item in this budget.
The next item relates to specialized foster care services. The recommended budget does not include a decision unit to support the implementation of a new specialized foster care service. Although approval of a Medicaid 1915I state plan option change to implement new services, which include intensive in-home supports, in-home crisis stabilization for the specialized foster care population. As discussed by the subcommittee in considering the Division of Child and Family Services budget previously, the 1915I state plan option for services is pending final approval. Final approval is currently anticipated for June. An analysis provided by the agency projects 520 individuals would receive services and estimate additional costs of $9.2 million, of which $3.4 million would be general fund in FY 2022. And $9.3 million, of which $3.4 million would be general fund in 2023. The costs in the agency's analysis are net of projected savings associated with reductions in other behavioral health treatments. The agency's analysis indicates projected net general funds over the biennium. However, there is no decision unit in the budget to support these costs. At the budget hearing, the agency indicated it anticipated savings in other services would offset costs. However, the analysis provided did already factor in those savings. To monitor whether the services would result in ongoing additional costs to the state, the subcommittee may wish to recommend issuing a letter of intent directing the agency to report annually on costs incurred and savings realized associated with the new specialized foster care services. Does the subcommittee wish to recommend issuing a letter of intent directing the agency to report annually on actual costs and savings associated with these specialized foster care services?
Members, any questions on the specialized foster care services? Seeing none, I'll entertain a motion.
I move to recommend issuing a letter of intent directing the agency to report annually on actual costs and savings associated with specialized foster care services.
A second?
Second.
I have a motion from Senator Ratty, a second from Assemblywoman Carlton. Any discussion on the motion? Seeing none, all in favor of the motion, please say aye. Aye. Any opposed? The motion carries with the members present. Moving on.
The next item is other closing items, of which there are 5. Fiscal staff recommends other closing items be closed as recommended by the governor with noted technical adjustments with authority for staff to make further necessary technical adjustments.
Members, there are a number of other closing items. Are there any questions on any of those? Seeing none, I will entertain a motion.
Thank you. I recommend that other closing items be closed as recommended by the governor with noted technical adjustments with authority for staff to make further necessary technical adjustments.
Thank you. Second?
Second.
I have a motion from Senator Ratty, a second from Assemblywoman Carlton. Any discussion on the motion? Seeing none, all in favor of the motion, please say aye. Aye. Any opposed? The motion carries. Moving on to our next budget.
The next budget is the checkup budget. There are 5 major closing issues, most of which are interrelated to decisions that have been made in the Medicaid budget. The first major closing issue relates to the FMAP rates. Similar to the Medicaid budget, FMAP rates have been updated and reprojected. In FY 2020, the blended enhanced CHIP FMAP rate was 91.46% and decreased to 81.64% in 2021 and is projected to decrease to 76.11 in FY 2022 and 73.88 in FY 2023, consistent with continuing the temporary 4.34 percentage point increase through to December 31st, 2021. The temporary increase in the FMAP rate in 2022 results in general fund savings, and the decrease in the rate in FY 2023 requires additional general funds. In this budget, overall, the changes in the base budget results in net general fund savings of approximately $576,000 over the upcoming biennium. Fiscal staff recommends that FMAP rates be approved consistent with actions in closing the Medicaid budget. Does the subcommittee wish to recommend approval of the revised FMAP rates, including a temporary 4.34 percentage point increase in the enhanced CHIP FMAP rate through December 31st, 2021 for FY 2022, and approval of the FY 2023 FMAP rates based on the May 6, 2021 federal funds information for states projection?
Thank you, Ms. Crockett. Members, any questions on the revised FMAP rates? See none, I will entertain a motion.
Thank you. I would recommend approval of the revised FMAP rates, including a temporary 4.34 percentage point increase in the enhanced CHIP FMAP rate through December 31st, 2021 for fiscal year 2022, and approve fiscal year 2023 FMAP rates based on the May 6, 2021 federal funds information for states projection. Again, with pleasure.
Second?
Second.
I have a motion from Senator Ratty, a second from Assemblywoman Carlton. Any discussion on the motion? Seeing none, all in favor of the motion, please say aye. Aye. Any opposed? The motion carries. Moving on.
The next item is checkup caseload. The governor recommends funding for projected increases in checkup caseload. Similar to the Medicaid caseload, this caseload has been reprojected in March based on February 2021 actual caseload and costs. Consistent with the Medicaid budget, the updated caseload projections assume the public health emergency continues through December 31st, 2021. There's a table on page 43 that reflects the governor's recommended budget and March updated projections. The updated projections are lower than recommended in the executive budget by approximately 5%, which equates to roughly 1,500 individuals per year. As previously indicated during the work session, the agency indicates that checkup caseload tends to decline when Medicaid caseload increases, as unfavorable economic conditions may result in people shifting from checkup to Medicaid caseload, which has lower income eligibility requirements. As caseload would be lower, costs would also be lower when compared to costs in the executive budget in the M200 and M201 decision units. There's a table on page 44 that displays governor's recommended and projected caseload changes. In total, the March caseload projections and FMAP changes decreased general funds by $1.6 million over the biennium, from 2.7 to 1.1 million. Total funding would decrease overall by 7.3 million, from 12.5 to 5.2 million over the biennium. Does the subcommittee wish to recommend approval of updated caseload projections for the checkup program based on March 2021 projections, assuming the public health emergency continues through December 31st, 2021, funded with 5.2 million, including 1.1 million in general fund over the biennium.
Thank you. Members, any questions? Seeing none, I'll entertain a motion.
I would make a motion to recommend approval of the caseload projections as described by staff on page 44.
I have a motion from Senator Reddy, a second from Assemblywoman Carlton. Any discussion on the motion? Seeing none, all in favor, please say aye. Aye. Any opposed? Motion carries with the members present. Moving on.
The next item is provider reimbursement rate increases. These are aligned with rate increases in the Medicaid budget with regard to mandatory rate increases, decision unit M101, based on the updated projection prepared in March and FMAP rate changes and Moody's Analytic 2021 inflationary rates. Costs of this decision unit have decreased from 3.9 million to 1.4 million over the biennium. With regard to decision unit E351, although the caseload has decreased when compared to the governor's recommended budget, the agency's calculations for this decision unit actually showed an increase, and upon further review, it appeared that there was an inadvertent miscalculation in the backup documentation that was applying the projected increase in the Medicaid budget to this budget. Due to the discrepancy in the calculation, fiscal staff suggests maintaining the amounts recommended in the executive budget for this decision unit. Although the division is not required to align coverage for services and rates with checkup and Medicaid, it does so for consistency. So fiscal staff would recommend the subcommittee approve rate increases consistent with its decisions, including enclosing the Medicaid budget. Does the subcommittee wish to approve mandatory and discretionary provider rate increases recommended by the governor at a total cost of 14 million, 3.6 million general fund, and 10.4 million federal fund over the upcoming biennium with adjustments for caseload and FMAP rate changes as appropriate?
Thank you. Members, any questions? Seeing none, I'll entertain a motion.
Thank you. I would make a motion to approve the mandatory and discretionary provider rate increases recommended by the governor as described on page 45.
Second? Second. I have a motion from Senator Reddy, a second from Assemblywoman Carlton. Any discussion on the motion? Seeing none, all in favor, please say aye. Aye. Any opposed? Motion carries with members present. Moving on.
The next item is, and those mostly mirror the service eliminations in the Medicaid budget. Based on updated caseload and FMAP rate changes, basic skills training elimination would result in total savings of about $89,000 over the biennium. Psychosocial rehabilitation services savings would total about $571,000. Over the upcoming biennium for biofeedback and neurotherapy, savings would total about $319,000 over the biennium. And similar to provider rates, the agency is aligned mostly in its coverage of services. So fiscal staff would recommend the subcommittee approve and disapprove service eliminations consistent with its actions in closing the Medicaid budget. Does the subcommittee wish to recommend approval of decision unit E682 to eliminate basic skills training for savings of $89,750, of which $22,777 would be general fund, and decision unit E684 to eliminate psychosocial rehabilitation for savings of $570,649, of which $144,812 would be general fund, and decision unit E685 to eliminate neurotherapy for savings of $318,938, $80,940 general fund savings, as recommended by the governor, adjusted for March caseload projections and FMAP rate changes. And if the subcommittee wished to align these with the approvals recommended in the Medicaid budget, that would be approve 3, but do not approve items 1 and 2 as shown on page 46 of the document.
Thank you so much. And members, to be aligned with the decisions we made earlier today, I would entertain a motion to make, approve this decision union with that alignment.
Thank you, Chair. So with that, I would make a motion to not recommend approval of items 1 and 2, and to recommend approval of item 3 to eliminate neurotherapy for savings of $318,938, $80,940 general fund savings over the 2021-23 biennium, and the adjusted caseload projections and FMAP rate changes.
I have a motion. I get a second. Second. I have a motion from Senator Ratty, a second from Assemblywoman Carlton. Any discussion on the motion? Seeing none, all in favor of the motion, please say aye. Aye. Any opposed? The motion carries with the members present. Moving on.
The next item is a budget amendment. This mirrors the budget amendment the subcommittee approved in closing the Medicaid budget. That would be budget amendment here, A216833178. This was not discussed at the budget hearing. The budget amendment, as previously noted, rescinds provider reimbursement rate reductions approved through Assembly Bill 3 of the 31st special session. In this budget, the budget amendment adds funding of $2.8 million, including $629,339 in general fund and FY 2022, and $30,657, of which $25,209 is a general fund reduction in FY 2023. There is an adjustment to correct unmapping for decision unit E351, which is major closing issue 3. Merge replaces general funds with intergovernmental transfers for a general fund reduction of $62,503 over the biennium, which results in the net general fund reduction you see in fiscal year 2023. And consistency with the Medicaid budget is also recommended for this item. Does the subcommittee wish to recommend approval of budget amendment A216833178 at a cost of $2.8 million, net general funds of $604,310 over the upcoming biennium?
Ms. Crockett, could you go ahead and do the other closing items, and we'll just do one motion?
Yes, there's one other closing item, and staff would recommend it be closed with the noted technical adjustments with authority for further technical adjustments.
Thank you so much. Members, any questions? Seeing none, I will entertain a motion.
Thank you, Chair. I would recommend approval, make a motion to recommend approval of budget amendment A216833178 at a cost of $2.8 million, net general funds of $604,310, and federal funds of $2.1 million over the 2021-23 biennium, and recommend other closing items be closed with the noted technical adjustments with authority for staff to make further necessary technical adjustments.
A second? Second. I have a motion from Senator Ratty, a second from Assemblywoman Carlton. Any discussion on the motion? Seeing none, all in favor, please say aye. Aye. Any opposed? Motion carries with the members present. Moving on to our next budget, 3245.
There is one major closing issue in this budget, which is the prescription drug rebate. The governor recommends establishing a standalone budget to receive drug rebate revenues in the upcoming biennium. Funding received in this budget would be transferred to the Medicaid budget to offset general fund appropriations and federal funds in that budget. Recognizing the magnitude and variability of drug rebates received by the agency, the 2019 Money Committees issued a letter of intent directing the agency to evaluate various drug rebate projection methodologies as a means of increasing transparency of drug rebates. The establishment of this budget is recommended in response to the letter of intent, which recommends the division recognize drug rebates received as revenues rather than offsets to expenditures. The division receives drug rebates from participating drug manufacturers through a federal program that helps offset the cost of outpatient prescription drugs. Rebates received are split between the state and the federal government based on the FMAP rates, and the state portion serves as an offset to general fund appropriations required to support the Medicaid budget. Currently, drug rebates are recorded as an offset to expenditures in the offline category of the Medicaid budget. There is overall no net fiscal impact to locating drug rebate revenue within this budget. Similar to other budgets, the amounts in this budget have changed as a result of the caseload reprojections and FMAP rate changes. There is a table on page 51 that displays the original amounts recommended by the governor with the revised amounts based on the updated projections, and the adjustments increase overall drug rebate revenues by $28.9 million and increase net general fund offset in the Medicaid budget by approximately $461,000 to align with adjustments in the Medicaid budget. Thus, the subcommittee wished to approve the establishment of the prescription drug rebate budget as recommended by the governor with noted technical adjustments.
Members, any questions? Seeing none, I will entertain a motion.
Recommend to approve the establishment of the prescription drug rebate budget as recommended by the governor with the noted technical adjustments.
Second?
Second.
I have a motion from Senator Ratty, a second from Assemblywoman Carlton. Any discussion on the motion? Seeing none, all in favor of the motion, please say aye. Aye. Any opposed? Motion carries with the members present. Moving on to our next budget, 3157.
This budget is the Intergovernmental Transfer Program budget, and it contains two major closing issues. The first relates to the continuation of the Managed Care Organization Directed Payment Program. The governor recommends continuing this program during the upcoming biennium. It was initially approved by the IFC at its January 27th, 2021 meeting, retroactive to January 1st, 2020. This payment program, there was a previous enhanced MCO payment program that was initially approved by the 2015 legislature. Due to changes in federal rules, that program needs to be phased out and sunset over a 10-year period. And in response to the pending phase out of the program, the agency developed an alternative in consultation with UMC in Clark County University Medical Center. And that is the MCO directed payment program. The program has been approved retroactive by CMS to January 1st, 2020, and allows for enhanced reimbursements targeted at public hospitals in Clark County. Currently, UMC funded with intergovernmental transfers provided by Clark County, matched with federal funds. In this budget, payments are based on direct services provided to Medicaid participants and are associated with quality measures to track effectiveness of enhanced reimbursements and improving health outcomes. Clark County would provide the non-federal share of payments, and funding would be transferred to Medicaid and checkup budgets and matched with federal funds and provide payments to UMC. When needed, a state net benefit is generated and transferred to the Medicaid budget to offset general funds. As discussed at the April 15th work session, the agency advised fiscal staff that projected supplemental payments associated with the MCO directed payment program in FY 2021, as well as in the upcoming biennium, would be lower than originally anticipated, resulting in a corresponding reduction in the state net benefit estimated at $14 million over the upcoming biennium, including caseload and FMAP rate changes. According to the agency, following discussions with Clark County and UMC, it was determined that Clark County is not anticipated to have sufficient funding to provide the originally projected non-federal share of the recommended payment program. Additionally, the recommended amount of supplemental payments would reduce UMC's compensated care, which there was a concern that could potentially lead to a reduction in UMC's disproportionate shared hospital payments. Fiscal year 2021 supplemental payments have also been reduced, creating a $5.9 million general fund decrease in the state net benefit, which has the effect of reducing the agency's projected fiscal year 2021 surplus. The previously discussed FY21 surplus numbers do factor that amount in there. In total, the change to the MCO directed supplemental payment program results in a general fund increase of approximately $14 million over the upcoming biennium in the Medicaid budget. The agency indicates a contract reflecting the updated intergovernmental transfers anticipated from Clark County will be submitted to the June Board of Examiners meeting for consideration. There's a table on page 56 that displays the originally recommended payments to UMC, Clark County intergovernmental transfers, and state net benefit, and the revised amounts based on updated information from the agency and caseload and FMAP rate changes. Does the subcommittee wish to recommend approval of continuing the managed care organization directed payment program with the noted technical adjustments to reflect updated Clark County intergovernmental transfers?
Members, any questions? Senator Keycoffer?
Thank you, Madam Chair. Ms. Crockett, this is a pretty significant hit to UMC. This following item is related to the continuation of dish payments. Do you know how much of this loss is offset by the unexpected continuation of the dish payments?
I do not have projected dish payments by provider type available in the upcoming biennium. At the moment, I don't know if the agency has those available, or we could certainly work on that and provide a follow-up to the committee as well if they don't have it on hand.
Not essential, but I can follow up. Thanks.
Any other questions? Seeing none, I'll entertain a motion.
I would make a motion to recommend approval of continuing the managed care organization directed payment program with the noted adjustments to reflect updated Clark County intergovernmental transfers.
Need a second? Second. I have a motion from Senator Ratty, a second from Assemblywoman Carlton. Any discussion on the motion? Assemblywoman Carlton.
And thank you, Madam Chair. I too have concerns about the impacts to UMC and the downstream effects of this, but knowing where we are at this moment in time, this is where I think we need to be, but I do believe there'll be future issues with this. Thank you.
Thank you so much, both of you, for getting that on the record. Seeing no other questions or discussions, all in favor of the motion, please say aye. Aye. Any in opposition? Motion carries with the members present. Moving on.
The next item relates to the disproportionate share hospital program, referred to as the DISH program. The executive budget had recommended participating hospitals receive payments of $33.9 million in fiscal year 2022 and $13.8 million in fiscal year 2023. A provision in the Patient Protection and Affordable Care Act, ACA, reduces federal DISH allotments on the assumption that there are fewer uninsured and less uncompensated care with the expansion of healthcare coverage. Subsequent legislation several times has delayed reductions to these federal allotments, most recently until federal fiscal year 2024 through the Consolidated Appropriations Act, which was signed into law on December 27th, 2020. The executive budget reflects DISH allotment reductions effective federal fiscal year 2021, as the bill that extended the time frame for reducing those allotments was passed very close to the governor's budget being completed. Based on the federal delay of reducing the payments, DISH allotments to the state would be higher than initially anticipated in the governor's recommended budget. There's a table on page 57 that compares governor's recommended payments to hospitals as well as the anticipated state net benefit and the revised amount, as well as the increases compared to governor's recommended budget. Payments to hospitals overall would be $131.9 million higher over the upcoming biennium when compared to the executive budget. And the state net benefit is currently anticipated to be 23.8 million higher than recommended in the budget, which has the effect of reducing general funds in the Medicaid budget by a corresponding amount. Technical adjustments have been completed in this budget and the Medicaid-based budget to account for this. Thus, the subcommittee was to recommend approval of the updated disproportionate share hospital program to reflect continued delay of federal reduced federal program allotments as authorized by the Consolidated Appropriations Act 2021.
Thank you so much. Questions from the committee? Seeing none, I'll entertain a motion.
I would make a motion to recommend approval of the updated disproportionate share hospital program to reflect the continued delay of reduced federal program allotments as authorized by the Consolidated Appropriation Act 2021.
Can I get a second? I have a motion from Senator Ratty, a second from Assemblywoman Titus. All in favor of the motion? Aye. All in favor of the motion, please say aye. Aye. Any opposed? Seeing none, the motion carries unanimously. Moving on to the other closing items.
There are 10 other closing items, and they outline updates to the various supplemental payment programs based on caseload and cost reproductions. Staff would also note that the budget amendments that is a companion to the amendments approved by the subcommittee in Medicaid and checkup is also incorporated into the other closing items in number 3. And staff recommends other closing items 1 through 10 be closed as recommended by the governor with noted technical adjustments with authority for staff to make further technical adjustments.
Members, any questions on the other closing items? Seeing none,
I would make a motion to recommend other closing items 1 through 10 be closed as recommended by the governor with the noted technical adjustments with authority for staff to make further technical adjustments.
a second?
Second.
I have a motion from Senator Ratty, a second from Assemblywoman Carlton. Any discussion on the motion? Seeing none, all in favor of the motion, please say aye. Aye. Any opposed? The motion carries unanimously of members present. Moving on to Budget 3160.
This is the increased quality of nursing care budget. There are no major closing issues in this budget. The executive budget recommends continuing the financing methodology approved by the 2019 legislature. Staff has made technical adjustments to align with the FMAP rate changes. And staff recommends the budget be closed and other closing item be closed as recommended by the governor with noted technical adjustments with authority for staff to make further technical necessary adjustments.
Members, any questions? Seeing none, I'll entertain a motion.
I recommend the other closing items be closed with noted technical adjustments with authority for staff to make further necessary technical adjustments.
Second?
Second.
I have a motion from Senator Ratty, a second from Assemblywoman Carlton. Any discussion on the motion? Seeing none, all in favor of the motion, please say aye. Aye. Any opposed? Motion carries. Moving on to our next budget, 3260.
That concludes the division of healthcare financing and policy budget. The next two budgets are budgets that are related to the Medicaid program and reside within the director's office. The first budget is the UPL holding account budget. The governor recommends continuing the UPL holding account budget in the upcoming biennium funded with transfers from other budgets within the department, totaling $11.9 million in each year of the upcoming biennium. The agency anticipates a nonprofit organization would provide certain contracted health-related services to state clients at no cost to the state in the upcoming biennium, as opposed to the state contracting with vendors directly for these services. Because the nonprofit organization would provide services, savings would be generated in various DHHS budgets, which would then be transferred over to this budget. There is a table on page 65 that lists the anticipated savings by program area within the department that would transfer over to this budget. And the transfers are anticipated to result in 11.9 million in revenue in this budget. There's a minor technical adjustment to align with some updated information by the agency regarding a couple of the contracts. After the adjustments and updating for FMAP rate changes, transfers to the Division of Healthcare Financing and Policy that are used to support the private hospital UPL supplemental payment program are anticipated to be 8.1 million in fiscal year 2022 and 8.9 million in fiscal year 2023. General fund reversions, which represent the state net benefit, are projected at 2.1 million and 1.7 million in 2023, and Healthy Nevada fund reversions, which also represent state net benefit, are projected to be 1.7 million in fiscal year 2022 and 1.4 million in fiscal year 2023. Regarding statutory authority for this budget, the account is reauthorized through language in the Appropriations Act. Every year, similar language would be needed in the upcoming biennium. The agency has requested to slightly modify the language to allow for a one quarter carry forward of funding from one fiscal year to the next, to allow for a reconciliation process to ensure that supplemental payments are made as intended. Does the subcommittee wish to recommend approval of continuing the UPL holding account as recommended by the governor in the upcoming biennium with the noted technical adjustments, and approve language in the 2021 Appropriations Act to authorize the continuation of the account and provide authority for further necessary technical adjustments?
Members, any questions? Seeing none, I'll entertain a motion.
I would make a recommendation for approval of continuing the UPL holding account as recommended by the governor in the 21-23 biennium with the noted technical adjustments, approved language in the 2021 Appropriations Act to authorize the continuation of the account in the 21-23 biennium and provide authority for further technical adjustments as necessary.
I have a motion from Senator Ratty, a second? Second. A second from Assemblywoman Carlton. Any discussion on the motion? Seeing none, all in favor of the motion, please say aye. Aye. Any opposition? There's none, the motion carries. Moving on to our final budget of the day, 3244.
This is the indigent hospital care budget, and there is one major closing issue, and that relates to the continuation and expansion of support for the Medicaid county match population. The governor recommends transferring funding, shifting funding from providing the non-federal share of Medicaid supplemental payments or one of the supplemental payment programs to supporting a portion of county's responsibilities to pay the non-federal share of Medicaid expenditures for indigent individuals who meets an institutional level of care. At the October 22nd, 2020 meeting, the Interim Finance Committee approved utilizing funding from this budget to support a portion of county's responsibilities to pay certain Medicaid costs, which did represent the previously noted shift in funding. The executive budget continues and expands its use of funding in the upcoming biennium. And with regard to background, in the 2019 session, the legislature approved revising the methodology for determining county financial participation for the non-federal share of Medicaid costs for certain county match participants, resulting in increased county reimbursements of 19.7 million over the upcoming 2019 through 21 biennium, and a corresponding reduction in general fund appropriations in the Medicaid budget. Under the revised methodology, counties would contribute entire non-federal share of costs for the county match participants, and certain waiver participants up to the proceeds of an 8-cent tax on each $100 of assessed valuation of all taxable property in the county pursuant to NRS 428-285. At its February 7th, 2020 meeting to address county concerns regarding rising Medicaid obligations, the board approved, and that's the Board of Trustees who oversees this fund, approved shifting $8 million in the fund to support a portion of county's obligations to pay for certain Medicaid costs in FY 2021 as authorized by NRS 428026. And the IFC approved this concept at its October 22nd, 2020 meeting. Through Decision Unit E350, the governor recommends continuing and expanding the shift of funding based on updated information provided by the agency that reflects amounts approved by the Board of Trustees at its February 2nd, 2021 meeting for FY 2022 and continues a similar use of funding in FY 2023. The shift would provide a total of $18.7 million in 2022 and $16.5 million in 2023 to support a portion of counties' Medicaid responsibilities. If approved, funding from this budget would provide 31.5% of the estimated non-federal share of costs associated with the county match population of about 35.2 million, with county reimbursements providing 67.1% or about 75 million, and the general fund providing 1.4% or about 1.6 million of costs projected to exceed the 8-cent cap of the 111.9 million total non-federal share based on the most recent caseload and FMAP projections. Actual costs will vary depending on Medicaid caseload and medical service utilization over the upcoming biennium. The recommended budget includes property tax revenues of $34.2 million and unmet free care assessments of $53.5 million over the biennium. On February 21st, 2020, the Nevada Association of Counties adopted a resolution expressing its support for utilizing property tax revenues in this budget to assist counties in supporting a portion of their Medicaid obligations. In alignment with this resolution, the general goal of the governor's recommended budget is to utilize property tax revenues for the Medicaid county match population and to utilize the unmet free care assessments to provide the non-federal share of the Indigent Accident Fund upper payments limit supplemental payment program within Medicaid, and also to provide the state net benefit associated with that program. Regarding the impact to the Indigent Accident Fund supplemental payment program, the agency estimates this decision unit would reduce supplemental payments from about 121 million to 70.7 million. In FY 2022, that's a $50.3 million reduction. And from 114.2 to 70.1 million, a 44.1 million reduction in FY 2023. During the budget hearing, the agency indicated it did not anticipate this reduction in supplemental payments to create access to care issues for Medicaid participants. There is a table on page 69 that displays the governor's recommended budget and updated based on Board of Trustees actions. And those changes primarily relate to the utilization of a 6.2 million projected FY 2021 surplus being used in FY 2022, being split roughly between the county match support use and the Indigent Accidents Fund supplemental payment program. Regarding distribution of funding to the counties, at its March 19th, 2020 meeting, the Board of Trustees adopted a methodology to distribute funding to the counties in 2021 based on a percentage of actual payments made by counties in FY 19 to the state for support of the Medicaid population. A similar methodology is projected to be used in the upcoming biennium. The board provided staff with a table on page 70 that displays the anticipated distribution by county in fiscal year 2022. Does the subcommittee wish to recommend approval of continuing and expanding support for the Medicaid county match population with funding from this budget, as recommended by the governor with noted technical adjustments by the Board of Trustees, and to transfer 18.7 million in FY 2022, 16.5 million in FY 2023 from this budget to the Medicaid budget to support a portion of counties' responsibilities to pay the non-federal share of certain Medicaid expenditures.
Thank you. Members, any questions? Seeing none, I'll entertain a motion.
Thank you, Chair. I would recommend approval of continuing and expanding support for the Medicaid county match population with the full motion as described by staff and on the bottom of page 70.
Thank you. Second? Second. I have a motion from Senator Reddy, a second from Assemblywoman Carlton. Any discussion on the motion? Seeing none. All in favor of the motion, please say aye. Aye. Any opposed? Motion carries unanimously. And members, that was our last budget. Ms. Crockett, thank you so much. We had a great discussion today, and we did some good work here today, so we can all leave and not have the tears I normally have at the end of our budget meetings. That brings us up to our last item on our agenda, and that is public comment. I will ask our broadcast staff if we have anyone waiting on the line who wishes to provide public comment today.
Anyone wishing to make public comment, please press star 9 now to take your place in the queue. Caller with the last 3 digits 528, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Madam Chair and members of the committee, for the record, my name is Barry Gold, Barrygold, and I'm the Director of Government Relations for AARP Nevada. What a great day for budget closings. I have sat through these meetings over the years, and very often very difficult and painful decisions had to be made. But today, things were very different. Some of those terrible decisions we had to make during the pandemic and the special session, you've been able to reverse. And something that I have talked about and asked about and implored has become a reality. One of my dreams has come true today. I've talked about the waiver programs and not just funding for caseload growth, but to eliminate waiting list. Wow, what a great day that the committee today and the governor recommend funding to eliminate the waiting list. As I've said before, people who have to wait too long, terrible things can happen. They go into nursing homes or they die. Well, not in Nevada anymore, because we're going to be able to put them into the waivers and get them the care they need in the community so they can be as independent and live with dignity as they want to. So AARP, yes, on behalf of the 345,000 members across the state, absolutely thanks you for funding those waiver programs for caseload growth and to eliminate waiting lists. Thank you very much.
Thank you, Mr. Gold. I believe Assemblywoman Titus wants to say something.
Just a general comment that I want to make it clear on the record that patients do not go into nursing homes just to die. Thank you.
Thank you, Assemblywoman. And thank you, Mr. Gold, for joining us in your comments. Next caller.
Caller with the last 3 digits 131. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
I'll do it at the end. I totally forgot about him.
Chairman Romarino, members of the committee, my name is Connor Kane, CONNORCAIN, and I'm providing public comment on behalf of Comprehensive Cancer Centers of Nevada. CCCN is proud to accept all types of Medicaid and treat a high volume of Medicaid patients. But like the last caller, we appreciate that you have had to make many difficult decisions over the past year as stewards of the state budget, and are grateful for your efforts, Governor Sisolak's efforts, and DHHS's efforts to restore Medicaid cuts. Thank you.
Thank you. Next caller.
Caller with the last 3 digits 202. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Thank you, Madam Chair and members of the committee. My name is Paige Barnes, PAIGEBARNES. I'm with Crowley and Ferrato Public Affairs, today representing the Nevada Nurses Association. We wanted to express our gratitude to the committee for restoring the Medicaid cuts to providers during the 2020 special sessions. As frontline providers, we've seen the devastating health impacts from the pandemic. We understand the hard decisions everyone had to make over the last year and don't envy those decisions you all had to make. But today we are happy to be here under better health and economic conditions Thank you for prioritizing Nevada's healthcare system, the frontline health workers, and our Medicaid patients, and for choosing to restore the Medicaid cuts. Thank you.
Thank you so much for your comments. Do we have any other callers on the line?
Caller with the last three digits, 836. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Thank you, Chair and members of the committee. For the record, this is Jessica Ferrato, Jessica here today on behalf of the Nevada chapter of the American College of Emergency Physicians. We represent more than 400 emergency physicians, and together we serve more than 1.5 million patients per year. We represent emergency physicians, emergency medicine residents, and medical students. Our members are part of the Nevada statewide team fighting daily on the front lines against COVID-19. 2020 brought unprecedented times to the state of Nevada. As frontline healthcare providers, we have seen and worked through the unthinkable moments over the last year. All Nevadans have been confronted with unexpected challenges and the devastating impacts from the pandemic. We know the decisions made by our state leaders last year were not easy. We want to thank the committee for restoring the 6% Medicaid cuts that were made last year. This is a significant impact for our most vulnerable patients and the healthcare system as a whole. Thank you.
Thank you. Next caller.
Caller with the last three digits, 582. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Good morning, Madam Chair and members of the committee. My name is Jaron Hildebrand, and I'm the Executive Director of the Nevada State Medical Association. Calling in today just to quickly thank the committee and echo all the comments of my colleagues before me. Nevada's healthcare providers have been anxiously anticipating the implementation of the 6% Medicaid cuts for the last 10 months, and today's action provides a huge sign of relief within the healthcare community of Nevada. We are grateful to the governor, his staff, and legislative leadership for prioritizing Nevada's healthcare safety net as we continue to recover from a global pandemic. The elimination of a retroactive cut will help ensure the access to quality care and timely care for Nevada's most vulnerable population. Again, we thank you so much, and I appreciate your time. Thank you.
Thank you. Next caller.
For those of you that have just joined the call, if you would like to make public comment, please press star 9 now to take your place in the queue. Caller with the last three digits, 122. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Good morning, Chair Monroe Moreno, members of the committee. For the record, my name is Katie Ryan, Katieryan, and I am System Director of Nevada Government Relations for Dignity Health St. Rose Dominican. Just as my other colleagues have previously said, I'm here today to thank this committee, Medicaid, and the governor's office for withdrawing the Medicaid reimbursement cuts from last summer's special session and then restoring rates back to what they previously were. We are extremely grateful for everyone's commitment to flexibility around this issue during this most unprecedented time. And as the chair said today, is a very good day for healthcare providers in Nevada. Thank you.
Thank you. Next caller.
Chair, the public comment line is open and working. However, we have no more callers at this time.
Thank you so much. And we have a number of people who have joined us here in the committee room, so I will invite you to come up individually, those that are here to make public comment.
Thank you, Madam Chair, committee members. My name for the record is Bill Welch, BILLWELCH. I'm here on behalf of the Nevada Hospital Association and all of our members. As been said by some of my colleagues, this is a great day. I've sat here since 1999 through many sessions, both regular and special sessions, where much different decisions had to be made, with very few times that we were actually able to see any progress made in reimbursement to providers for healthcare services and Medicaid. With that, I'd like to say on behalf of the members of the Nevada Hospital Association and all Nevada healthcare providers, I would like to thank the governor and this body for its efforts today to restore the Medicaid cuts imposed in the Nevada's 31st special session. Hospital and healthcare workers, excuse me, faced unimaginable circumstances over the last 15 months. And Nevada faced an unprecedented state budget crisis as a result of the recent pandemic. The governor's commitment to remaining flexible and working closely with you, this legislative body, during this unprecedented and evolving fiscal situation made the difference in the lives of many Nevadans and Nevada's ongoing economic recovery. Restoring Nevada Medicaid proposed reimbursement cuts to hospitals and providers will be instrumental in safeguarding health care available to the citizens of Nevada as well as all of our visitors. Again, on behalf of the members of the Nevada Hospital Association, we appreciate your support today. Nevada hospitals and providers look forward to working with you and the governor in our state's efforts to successfully cross the finish line in the battle against COVID-19. Thank you again for your support today.
Thank you so much for joining us, Mr. Welch.
Good morning, Madam Chair. Paul Moradkin, MORADKHAN with the Vegas Chamber. The Chamber also would like to reiterate its appreciation of the work of the subcommittee and Governor Sisolak in restoring the Medicaid reimbursement rates. We believe it's good fiscal policy and health care policy. Thank you very much.
Thank you, Mr. Moradkin.
My name is George Ross. I'm testifying on behalf of HCA Healthcare, which includes Sunrise Children's, Mountain View, and Southern Hills Hospital in Southern Nevada. HCA is very grateful to the governor and his office and this committee for restoring the Medicaid cuts, in particular to going back and paying and providing the payments for those cuts that had to be made last summer. And we understood that, but we really are very grateful for having that money restored, as well as bringing the rates back up to where they were prior to those cuts. Sunrise provides the highest amount of Medicaid care in the country, in the state rather, 42% of its patients, 56% of its emergency room are Medicaid. And this restoration by you all makes a big difference to that hospital and those people. Thank you very much.
Thank you, Mr. Ross. Next.
Thank you, Madam Chair and Committee. Misty Grimmer with the Ferraro Group representing North Vista Hospital. I would echo the comments of my other colleagues in the hospital industry and thank the committee and the governor's office and Mr. Whitley and his team for restoring the Medicaid cuts. I know the cuts were hard to make and you guys have a lot of other needs for the money, but we really appreciate that you've restored these cuts.
Thank you so much.
Good morning. Thank you, Madam Chair. Dan Musgrove on behalf of the Valley Health System of Hospitals, 8 hospitals throughout Nevada and soon to be 9. And, you know, it was a very, very tough summer for all of us, especially in the healthcare world, but for this body as well, and all the hard work that you had to do in the special sessions to try to make sure that we had a balanced budget. But here we sit today, and I just want to thank all of you as well as the governor and HHS for the work that was done to restore the cuts. It means a lot to our first responders, our frontline healthcare workers, and our hospitals, so thank you very much.
Thank you.
Good morning. My name is Chris Bosse, B-O-S-S-E. For the record, here today on behalf of Renown Health. I don't have anything additional to add, just want to share my heartfelt thanks to the governor, DHHS, and this subcommittee for your support today, and ditto on all the other comments that my colleagues have shared with you today. Thank you so much.
Thank you so much. Well, it appears that is the last person we have for public comment. And committee, with that, this meeting is adjourned, and I wish you all a great day.